For the oration, the chairpersons are Dr. Bela Bhatt Madam. She is consultant at Dr. Bela's Women Health and Fetal Medicine Center, Vice President-elect Foxy 2027, and she is Secretary of AFG. We also have Dr. Manohar Motwani sir. He is ex-honorary at Rajawari Hospital, Director at Carberry Nursing Home, and he is past President of Association of Fellow Gynacs.
Third chairperson is Dr. Mukesh Patil sir. He is Director of Mukesh Patil Center for Women's Health, Director of Lakshmi My Nest Pluro Fertility and IVF Center, Secretary of the Vasai Narasopara Virar OBGY Society. We also request Dr. Jayanti Kamath Madam to please join. She has a fellowship in advanced fertility from Israel, IVF consultant, obstetrician and gynecologist, ex-assistant honorary HBT and Cooper Hospital. She is the recipient of Wonder Foxian Award, Women Iconza Award, Times Group, and she is treasurer of AFG. Welcome, ma'am. I would request the chairpersons to please call upon our orators.
So it's our honor to invite the first orator for this very important AFG CME, and that is none other than Dr. Rishikesh Pai sir. I am sure sir does not need any kind of introduction. So the first connection with all of us of sir is our past president of FOGSI 2023, and I have been fortunate to work under sir as the chairperson Imaging Science Committee for an entire year, and what wonderful academics we had throughout the year. And we all know sir is a medical director, Bloom IVF, professor reproductive medicine, D.Y. Patil University, FIGO trustee Asia Oceania 23 to 25, and Assistant Secretary South Asian Federation of Obstetrics and Gynecology from 2023 to 25. Sir, we know you have vast experience in the field of IVF, and you do a lot of use of artificial intelligence in IVF. So, sir, we would like to hear from you, sir. Over to you, sir.
Thank you. Thank you. I would first and foremost thank Dr. Rajendra Sarogi, and of course, my friend Dr. S.N. Agarwal, Mohan Gadam, and a lot of seniors are here. And the President, Dr. Nitin Shah, Dr. Bela Bhatt, Jayanti Kamath, Mohit Sarogi, Rupa Prasad, Shrutika Thakkar, and Sheetal Sravankar for calling me here. Historically, the word AI was coined by John McCarthy and Marvin Minsky in 1956 in Dartmouth. But AI came into public focus in 1997 when Gary Kasparov was defeated by IBM's Deep Blue computer in chess using basic AI. So if you look at artificial general intelligence applications, there are many, but the most is the last application which is very important for us in medicine, and that is called machine learning, which is the study of computer algorithms that improve automatically through experience. So if you look at machine learning, there are several machine learning techniques, and there are 5 of them, but we are more interested in the last of the techniques, which is the artificial neural network, which includes the recently developed deep neural network. So what is artificial neural network? Which are made up of artificial neurons, which are simplified mathematical models inspired by brain behavior. A neural network typically consists of several layers of artificial neurons fully connected to each other by edges. So, but it's not an actual neurons, it's a virtual neuron. So the transistors and the chips, they project a virtual network, and that is used for computing, and the computation language is algebra, that is mathematics. So the brain language is biochemistry. If you have brain synapses, it goes by biochemistry, synapses, release of biochemical, and then impulses are electrical impulses. But here the computation is based on algebra. The transistors are having algebra. So how does AI learn? You provide data, images, text, signals, and the AI predicts an outcome based on the algebraic calculations which are done rapidly, and the errors are measured, and model adjusts by internal weights and repeat it millions of times. So slowly they start understanding and becoming better, and this is called training. So if you look at what is the AI learning and doctor learning, if you differentiate, so doctors will learn from patients over the years, builds judgment. AI will also learn from millions of data points, build statistical prediction, So doctor is a biological neural network. As I told you, biochemistry plus electrical pulses, while AI is the silicon neural network, it's all mathematics and algebra. So if you look at normal computer and artificial intelligence, what is the difference? A normal computer is rule-based. It has fixed instructions written by humans, cannot learn beyond programming. Whatever the program is, it will base itself on the program. But artificial intelligence learns from data and finds patterns automatically and improves performance over time because it has got a machine learning capacity. So for the hardware, a normal computer has what is known as a CPU, computer processing unit. Few powerful cores are there. Sequential processing is done, but good for general computing and logic. While an AI needs a graphic processing unit, it is called GPU. It has thousands of small cores. Parallel processing is done, and ideal for, so initially these chips were used for gaming. Gaming needed a lot of, or they are also used in missiles. So those chips have very high speed, and that's our graphic, and AI workload requires parallel math, and GPU is dominant in it. So if you look at global AI infrastructure, the reality is that everything is based on one big chip, which is made by NVIDIA. It's the backbone of modern AI computing. All labs worldwide, they use it because NVIDIA not only makes the chip, there are many other companies that make that chip now, but it has the hardware, the software stack, developer ecosystem, and cloud integration. So other things other than the chip, together they form the power base. And this is the Jensen Huang, who is the king of NVIDIA. Just I was coming to your place, I just opened my Instagram. The Mercedes-Benz has just finished 140 years, and Jensen Huang is coming out. I always wanted to buy my S-Class, so I'll wait for it. He's coming out with a new S-Class with owner of Mercedes-Benz and Uber, owner of Uber. Three of them are getting together and coming out with a new S-Class, fully automated. So I'll wait for that. NVIDIA is in USA. What it does, it designs the chip. After that, it is sent to the Taiwan. My son is gone to Taiwan for, that's why Rishma is not there, for robotic surgery training. So Taiwan has TSMC, which is the biggest chip maker in the world. They make the chip, they engrave the chip using a machine which is called ASML. The only machine, ASML is the only company that makes that machine, lithography machine. It is based in Netherlands. One machine costs $350 million. Only one machine. Only one company makes it. No, everyone has competed, but they can't beat the precision of ASML. So this is how it is done. The US designs it, it goes to Taiwan, Taiwan has the chip, the lithography machine designs, and the chip goes back, and then NVIDIA assembles it. There's a lot of transistors along the chip. Together they make the computer. So the biggest problem which is there is that the heat generation is too much. Imagine, the other day I had gone to my Gurgaon center, IVF, बाहर 5 ACs were there. My God, heat was so much. मैं बोला यार कुछ तो आग भी लग जाएगा. So the heat generation is massive, and that's why you need 3 types of cooling are there. So if there's a basic unit which costs 4-5 crore rupees, by the way, a basic unit which you put in your hospital, for example, of AI, where there will be air cooling, then there's a liquid cooling, and you can see there is also a data. So many of the servers are now put under the sea, in the sea. And one of the things that what Elon Musk wants to do is take the server to moon, where the servers, or Chinese want to put them in the satellite. So the cooling is there so that it can keep the server temperature down. So where does the NVIDIA chip sit? So it sits, there are 3 locations where it sits. One is inside the device. It can be in the server in your hospital, or it can be in the cloud, in the main server base. At present, we do, so if you have an embryoscope, which I have for last 12 years now, there's a new one. So the embryoscope will capture the data, the images, we have an internet connection, it is transferred to servers in Sweden, where the AI is there. AI will calculate, do the grading of the embryos, and send back the report. So in clinical practice, we have 4 applications of AI for gynecology. One is cervical and ovarian cancer, one is obstetrics. at some point in time, already there are many programs which can say, Acha, this patient will go for cesarean or it will not go. So at some point in time, government will bring a program and say, if the program says cesarean, you do cesarean. If it don't say cesarean, you don't do cesarean. So that program will be brought based on multiple parameters. And then precision medicine, that in the future, multiple parameters will be taken, and if you go to a GP and you have got pain in abdomen, based on the computer, different people will be given different medicine based on what the homeopath does. He takes your detailed history and all that, so and then puts an output. So in reproductive medicine, one is admin. So admin, electronic medical records, minimizing patient stress, uniform workflow distribution, stock taking and inventory, QC QA, expiry and replenishment of medicines, expiry of license. 3 महीना पहले PNDT is going to expire, tong. So you will know कि PNDT license is expiring, data analysis and research. But in our clinical practice, ultrasound, number one. So AI will identify uterine anomalies. Already 3D sweep is there. So I tell all my patients to go to sonologist, they do a 3D sweep, everything is picked up. Then evaluation of the endometrium, AFC count, already one lady is after my blood from USA. So automatic, there are 3-4 programs now, just you put the probe and automatically it calculates the number of follicles and also automatic calculation of gonadotropin dosage and endometrial receptivity also, it's all going to come. Then of course we have the semen. So in male, you can predict male infertility outcomes. You can also predict likelihood of sperms extraction in azoospermia by protocol. You can say whether this guy will get a, what is the Aphrodite criteria, but it's computerized now. The development of smartphone, you can do now, all of us in all our labs, we have automatic, we just put the drop and put it gives 11, 12. Originally CASA was there, was very costly. Now it's just very cheap. This costs 1.5 lakh rupees. Per sample it is 500 rupees, just put it, plug it in and throw it away. So this is the machine, just plug it in. And now there's a new machine, so I'm crazy about machines. That's why I never made money in my life, because I keep on buying machines. Because I believe in passion of life. I don't care about money. I believe in internal happiness. I like to enjoy my machines, and that's where my passion lies. So this is as far as then you can identify. So in the testicular biopsy, I remember when I went to, many years back, 25 years back to Texas, Dolores Lamb, the queen of TISA. They said, sir, आज एक patient is there, 8 hours will be synced. 2 pairs of embryologists, 8 embryologists will check the sample for 8 hours, because this is the last time वो biopsy NOA का है, उसको sperm नहीं मिला तो we'll have to go for donor. 8 hours they checked for the biopsy. They charge $40,000. But superb. एक check करते हैं, एक खड़ा रहता है, एक check करते हैं. So you can, if you miss on the screen, they can pick up the sperm. Now this guy has come out with a new program, automatic pickup, based on the morphologies, the size, the movement. तो होता ही नहीं है biopsy specimen में, but in the just by the looking at the shape, computer can tell you where is the sperm. The guy who devised this got the prize last year in the ASRM. Then of course the AI assisted injection. So one of the things which can actually improve your outcome is the embryo quality. The genetic embryo, you can't do anything with the oocytes. There are 9 oocytes, 10 oocytes, you can't change them. But you can pick up the right sperm. The sperm pickup can still improve your embryo quality, can give still better embryo quality, better genetics. And this is the SID program. So you can actually hook up your computer, and as you are doing ICSI, Dr. Madiola in Mexico, he's got a SID program lab. They will tell you which sperm to pick up using the 3 parameters, that is sperm straight line velocity, linearity and head movement pattern. And you can pick up the best sperm which will give the best chance of genetics. A genetically competent sperm can be picked up. Then ovulation. So in the women area, AI can be used for prediction of ovulation, timed intercourse, IUI. You can do natural cycle FET exact. There's a guy in Israel, they charges $50. Exact will tell you the best time of doing the embryo transfer. If you want, and then by 10% you get a better pregnancy rate. But I said, I keep on traveling, so I adjust my transfer based on my travel, and I start my progesterone, so I can't use this program. If the program tells me do the transfer today and I'm in Delhi or something, how will I do it? But People who don't travel, you take this program, you will get a 10% increase in your pregnancy rate. Then, of course, oocyte grading is another thing which is there. So, oocyte grading prior to IVF. So, there are two programs which are there, Violet and Magenta. I bought this program in 2020. 5 years I am using it. I pay $100 per program. So, the oocyte can be picked up, analyzed. So, if a patient comes to me and says that, because we get a lot of patients who are egg freezing. So, if she has 8 eggs, I can analyze the eggs and tell her whether she needs one more cycle based on AI. And there is this study which they did on this program, where they had studied 17,000 oocytes. And in a balanced test, 300 oocytes were studied by 17 embryologists. And they found that the pregnancy rates were higher where the machine predicted the oocytes. So it's a very good test. So this is the test where we actually attach the camera and then the eggs are dissected. We also have a technology in the lab called spindle check. So we can see the chromosome spindle. So if you freeze the eggs after chromosome spindle is there, the results are very good. When you are thawing also, when you thaw the eggs, if you wait for the spindle to reform, the results are very good. So I have a spindle check in both my Mumbai and Delhi lab. So with this grading, it's become very better. Then, of course, embryo identification to improve pregnancy rates has always been a thing. So you can do PGTA, but it's invasive. We have to slowly go away from PGTA. You can do PGTA with artificial intelligence. So the geneticist can predict it better. You can do non-invasive PGTA. I got the first time into India in 2019 from Shanghai. Then time-lapse incubation, again a beautiful machine, and static imaging. So if you don't have any money, you can do static imaging. It's very good. It gives very good input. In fact, I used to use Life Whisperer for 5 years. Unfortunately, the company was bought by Kitazato or Aztec. So, unfortunately we couldn't. But now the new company, Sky Systems, has come in. So you can just click the blastocysts. If there are 4 blastocysts, click them, upload it. Within 2 minutes, you can prioritize which blastocyst to put inside to get the best chance of pregnancy. You can also do time lapse. It's a beautiful. I got 2 machines, but I wish I had the money. I would have put. I had a friend who I met from Germany, owner of a IVF center. He said, "Sir, hamara time lapse hai. We just see the phone on the phone. They come in my house. I can sit on the dinner table. I can see the time lapse. Everything." When I went to EV now, 4-5 years back or 6 years back, 35 time lapse in the EV Valencia. They do about 6,000 cycles. It's a fantastic machine. It gives grading out of 5 and out of 10. Superb grading. But that's not AI. For AI, you have to pay $5,000 more. This year, I'll probably buy that AI. But that gives you grading of the embryos based on the time-lapse videos. So it's a lovely machine. Then, of course, you have AI which can predict miscarriage also. So then coming to robot. So you need to know about robot because robot is a new thing. Whatever we call it. It's not autonomous. Operator controlled, enhances vision and dexterity, and human judgment remains central to it. And if you look at the robot, its precision is critical for fertility. Egg and sperm damage reduction is important. Standardization and reproducibility is a must. And reduced operator embryology fatigue is there. So you can do ICSI, embryo handling, and cryopreservation with robots. And this is the automatic vitrification. If you have got the day after tomorrow, my friend Dr. Santiago Muniz is coming to Mumbai. In Grand Hyatt, we have a function. So he's launching the Divitri automatic. Because there's a problem. Even in my labs, sometimes they perform well, sometimes the embryologists don't. It's a human problem. You can't. So if you look at the performance is variable. Embryologists, so you do PGD, you may have a fantastic result, but you may have damaged the embryo already. That's why I prefer non-invasive PGD. You may get the result, normal, but you may have damaged you can't make out the damage. So the Darwin 3 is a automatic oocyte and embryo automatic. Everything automatic, no cut, no dependent on the embryology, whether she is performing well or not. So we are replacing all we are bringing this machine everywhere. So now come to robotic ICSI. So there are 2 types. First is what Santi has got is the automated robot, which is mechanical automation, computer controlled injection. Embryologist selects the sperm and oocytes. There is no machine learning. Births are reported in 23. But It is controlled manipulation, precise injection, reduced oocyte trauma. But the real breakthrough came in 25. Badiola, my friend from the group is damn good, from with Cohen's group. So AI XC, so it's a next generator. Everything is done by automated steps. It's a computer vision pattern, and I would like to show you the XC. It's a 23 workflow, and this is the XC I would like to show you. Totally automated. So the automated robot at present is costing 5 crores, but this machine may cost 20 crores. But at some time, we'll bring them all in. And that's what it is. So automatic, you see all the steps are done by the automatic AI, looking at the vision, computer software, the touch, the pressure, everything, picking up the immobilizing of the sperm by laser shot, picking up the sperm injection, everything is done by the machine. Of course, at some point we'll have to buy it. So that's how it is, because we keep on evolving ourselves. It's very exciting it's an exciting time. So the robotics are going to come, but of course cost, access, but things will change now. Already Mumbai has got 45 robots, and people will keep on buying. The new Mantra robot has come into India for surgery, laparoscopic surgery, which is 5 crores, so it's cheaper than the Da Vinci. So things will become a reality. So robotics is consistency, and humans is the judgment. Together, the hybrid model will be the right model. So what is the future? You may have a semi or a full automatic IVF lab. AI decision support will be there, and there will be precision robotics. So this is what I wanted to show you. This is from Badiola. This is the normal now. They have a company called Conceivables. They have just got a second round of $70 million. And this is the automated robotic lab. Everything is automatic. Right from. So at present, the ICSI is from the oocyte holding sperm pickup, it's automated. But at some point, because there is a problem, embryologists may miss out on eggs also, so egg pickup will be also automated. Everything will be automated. So this all will go automatic, in and out, in and out. You just have to feed the chambers, and the first babies have been born already. This is totally automated, but the step between the egg holding and the ICSI has been taken care of. This is Dr. Cohen's lovely paper. Just now, before I came, I was reading this paper. Jack Cohen is the one who, what are the steps? And before I leave this, I would like to show you, this is the final automated lab. So you will have patient workup, virtual consultation, then they will come, the pickup will be done under ultrasound. Again, virtual guiding will be there. You can guide, the machine will guide you, will tell you what is what is not. Then automatic will go into the chamber. There the analysis will be done. The oocytes will be dissected by microfluidics. Then it will go to the robotic ICSI phase. From there it will shift to the embryoscope assembly, where the embryo will be cultured. And then when you load it, again the machine will tell you exactly where to load it, how to do it, everything. So everything will be, and the freezing will be also, as I told you already, automation has come in the freezing. So future of AI in medicine, what is this? Next 10 years, one is that fertility and IVF, AI-assisted retrieval and transfer, personalized stimulation protocols, and fully or semi-automated IVF lab. Based on the money that you have, if you have 10 crores, you will be a fully automated. If you have 5 crores, you will get a semi-automated. Healthcare systems, predictive medicine and prevention, remote monitoring and tele-care. And doctor's role will be from information provider, decision leader, to super intelligence. So what is super intelligence? Human judgment plus AI intelligence is the super intelligence. So everyone says AI in medicine will be a tool, it's not a threat. So AI is not an autonomous decision maker. It is clinical support system. Human oversight is central. Final responsibility lies with doctors and institutes. And there are checks and balances. Human in the loop decision models, regulatory approvals are necessary. And analogies like nuclear systems, AI operates under strict human control and governance. AI should be seen as a clinical ally, supervised and controlled by humans. So what are the jobs that will be lost? Jobs likely to decline. Yesterday only, my daughter sent this article. Because the new ChatGPT that has come in was made by ChatGPT fully. without programmers. So programmers are going to lose their jobs. So computer-based routine work, data processing, documentation, repetitive office tasks. You know, my secretary na doesn't come on time. पहला मैं उठा निकाल दूंगा, फट करके. 24 hours secretary will be there, automatic everything. Already we have taken the ERP system, voice control ERP system we have already installed. So healthcare workers, so jobs likely to remain strong. Healthcare workers, doctors and nurses, caregiver roles, and skilled manual professionals. So AI and jobs, what will change? Role of robots will be repetitive physical work, industrial and logistics support, robots will. So now what the Tesla owner has done, Elon Musk, that he's made a robot also. It's called Optimus Prime. It's already doing somersaults and all. And he said that it will replace us within 4 years. It may replace us. We don't know because so there are two types: machine AI and actual robot AI. Robot AI we don't know when it will work, but at least it will not come in my time. Future role for humans, from task performers, supervisors of intelligent systems, to AI will respect tasks. So not human. So this is the final slide. So what is the future? So future may be human augmented by AI. It is called super intelligence. So humans working with embedded AI systems. So this is a man, his name is Mr. Begin. He was quadriplegic. So they implanted a chip in his brain and put the electrodes on his hand, and by thought he can move his arm and all. So that's a massive jump in the AI. So these kind of combinations of humans and the AI will be there. Brain computer interface, wearable or implantable AI, assistance, robotic augmentation of human capability, and possible future applications, neuroprosthetics. I just now was seeing on the television the other day that there's a thing, they just put it on a back and it could move very fast. You must have seen that video. AI memory and cognition support, and surgeon will have robo-neural interfaces and precision control of medical devices. So in conclusion, in the future, medicine will remain a human profession, supported, not replaced by artificial intelligence. Thank you for a patient hearing.
Thank you, Dr. Pai sir, for that informative talk, and really impressed about certain things like non-invasive PGT. And soon I think an embryologist will sit at home and do ICSI at 5 different centers.
Right.
Any questions? Any questions? No? No?
Question
Okay, fine. So I would request our chairpersons to kindly felicitate our orator. Along with, I would request presence of our president, Dr. Nitin Shah sir, and Dr. S.N. Agrawal sir.
Hello friends, after this mesmerizing, fascinating lecture, I think it's a little scary the way things are. I think we may very soon become defunct, and Rishi, whatever you say, AI does everything. A state shouldn't come. It's my fear in life. I may not be alive to see it. Cerebral atrophy of human beings with the way things are. Anyway, here I have the pleasure to invite Dr. Jatin Shah, the most well-known ART specialist in the country. I would put him that way because I know him to be that way. Well, let's look at this gentleman. He's done his entire education from KM Hospital, my own hospital too. And in the year 1990, he cleared his MD. He was the part of the first IVF baby team. Now, if you remember that time, it was in Dr. Indira Hinduja's unit. He was a part of the unit. And that's how we all started. And looking at the foundation of this gentleman, you won't be surprised to see the end result of this. You know, it's a saying in Hindi, we say, chota parcel, bada dhamaka, but that's exactly what he is. Just look at the numbers in case you can see CV slide. It's phenomenal, the number of couples he's given babies to. whether they are celebrities or non-celebrities, among the most well-known names and celebrities, but he never mentioned the name because he's sworn to secrecy anyway. But we got to hear it from the surroundings, who's who in his entire beneficiaries. And well, I've known him personally for a very long time. He has reached the pinnacle of his success, I must say that. But to me, he's the same old Jatin. He's been grounded, loving. He just has no airs at all. So that's how we look at him. Now look at this day. On a Sunday afternoon, he finds time for AFG. He had his own commitments, but he said when it comes to AFG, and of course, our president, sir, who would have been as responsible to have him here. So Jatin, it's always a pleasure to listen to you. You're a powerhouse. So just one more thing before we start. You're called as the IVF commando. What does it really mean? This is what the net says on you.
That was given by Dr. Malhotra in Agra.
Exactly.
Because we didn't have embryologists in those days.
Yeah.
So I would do a pickup, go in to screen the eggs, then wash the sperm, then come back to the next pickup.
Okay.
So it used to go on like that.
Well, that's Jatin for you. Over to you, Jatin, please. Thank you.
Thank you so much, dear chairpersons, ladies and gentlemen. It's always a pleasure to be here, and thank you, Mohit, thank you, Nitin, thank you, Sheetal, Shrutika, everybody who's been part of this wonderful conference. And it's going to be a huge anticlimax from AI back to IUI. But I guess there are a lot of gynecologists here who still don't do IVF. So I've just included a very small capsule on how to do the perfect IUI, and then we'll jump into what really has changed in IVF. So of course we all owe our existence to this life-changing event that happened at the stroke of midnight, 25th of July 1978. But the reason for putting this slide is that Louis Brown was born from an oocyte retrieved in a natural cycle, no stimulation was done, and from an embryo that was replaced fresh and in the natural cycle as well. And today, after so many years, I'll show you that what's really changed in IVF is that we need to go back to nature and try to do more and more things that are towards nature rather than adding so many supplements and add-ons and what all do you have. So how we have evolved, of course, we all know after IVF. Actually, if you ask me, there have only been 3 big breakthroughs in the treatment of infertility. First was, of course, IVF. Second was ICSI in 1992. And third was vitrification. If you all look back, tell me what has really increased our success rates except these 3 things. And that is where we need to do a lot of soul searching. Because if you just do a simple chat GPT, looking at the European success rates, for the past 10 years, it's pretty much steady between 25 to 30% with self eggs and 60% with donor eggs. So if these add-ons were really working, why isn't that 30% increasing? In India, why isn't our 40% increasing? Because of course we have younger patients. So that is a question we all need to ask. But of course, for those who are not doing IVF, I'm not going to give a whole lecture on IUI, but just give you one straightforward, simple, easy to use protocol, just one protocol. Letrozole 5 milligrams day 3 to 7, and this works beautifully for your anovulatory as well as unexplained infertility patients. Call her in on day 8. The minute you see a lead follicle, begin HMG 150 with cetrorelix. Continue both until the follicle reaches 19 to 20 mm. And on that day, for example, today morning she is 19 or 20 mm. I will give her cetrorelix in the morning. I will give her the HCG trigger at 3 p.m. in the afternoon to have a precision timing of ovulation. And this works so beautifully, you will almost have a less than 5% incidence of LUF or anything going wrong. And Tuesday morning, she will come in with her husband at 8:39. She will have beautifully just ovulated. You process the semen sample and do a well-timed IUI. So cetrorelix addition is very important whenever you do any gonadotropin cycle. And as far as trigger and timing is concerned, I told you in letrozole cycles, as the study showed, 19 to 23 mm is the best. In clomiphene cycles, you can go 1 or 2 mm more to maybe 21 or 22 to get a higher chance of pregnancy. Yes, we don't have to follow all the guidelines because you know in the West, most of the women are about 34, 35, so maybe they don't like to use gonadotropins and do expensive IUI cycles. But in India, for a poor responder, we can always add one gonadotropin IUI cycle. And that again, you just begin with 75 or 112.5 of FSH. I'm talking about, say, a 32-year-old with an AMH of 0.7 who's not keen to directly jump into IVF, and she doesn't need IVF directly. You can do one gonadotropin IUI cycle as well. And as I showed you, the time interval is very important. So you don't need to do an IUI before rupture, after rupture, 1 day before, and so on. A single IUI at 42 hours post HCG usually suffices and will give you the best success rate. So let's move on to the main lecture and what's really changed in IVF. The number one change is individualization, and a lot of clinics don't do individualization. You cannot have the same set protocol for every patient who walks in. And to help you individualize not only your choice of protocol, your choice of analog, the dose of gonadotropins, fresh or frozen transfer, day 3 or day 5, adding PGT and so on, day 1 you have to look at age, BMI, AMH, AFC, associated PCO, endometriosis. This all of you know. But for a center like ours which deals with 90% of patients being IVF failures from all over the world, I feel the most important parameter for me is to study the previous IVF cycle. So you have to go into great details. What was the pre-treatment used? Was it a short antagonist or a long agonist? Did they use pure FSH, rec FSH? Did they add LH from the beginning or from day 7 and so on? How did she respond? What was the triggering criteria used? Did she have 12 follicles and gave only 5 oocytes? Did she have 12 oocytes and only 3 were M2s? All these are very valuable clues for you to make sure that you don't repeat the mistakes which were made in the previous cycle. But despite our best efforts, whatever we do, we all are faced with the commonest problem of Poseidon 1 and 2. And this, all of you would agree, is the major chunk of our patients. Patients who walked in with a normal AMH and AFC, you thought she is going to give you 15-20 oocytes and probably a first shot pregnancy, but she ends up with just 3 oocytes or 5 oocytes and gives you a suboptimal response. So Poseidon 1 and 2 you can't avoid, it's unexpected. And you also have Poseidon 3 and 4, and 3 is of course the majority of patients that all of us have. Young patients with a low AMH, and this is almost reaching epidemic proportions now, because I feel every second patient who comes has a AMH less than 2, even if she is 28, 30, 32 years old. So we need to master the art of how to treat the Poseidons 1, 2, 3, and of course 4, which are the women of advanced age, about 35, which you often give up on, but they also don't do that badly with the right choice of protocol and analog. So let's begin with, of course, Poseidon 1 and 2. What could have gone wrong? Why did a young patient with a normal AMH give you just 4 metaphase 2 oocytes when you were expecting at least 15? Commonest low starting dose of FSH. Now, if you start with 150 and see 4 follicles on day 7, then stepping up to 450 is not going to change that number. So please be very clear that you have to start with the correct dose. Number 2, 10%, 15% sometimes might be carriers of genetic polymorphisms, because of which the ovaries are insensitive to exogenous gonadotropins and they need a lot of LH right from the beginning. Number 3, your trigger was not adequate. Maybe you didn't give it on the right day. Many a times when I go back into the history of the previous cycle, I just ask the patient 2 things. On day 7, do you remember if one follicle was large and the others were lagging behind? And we think patients don't notice all these things, but 7 out of 10 patients tell me, yes doctor, without seeing the sheet, how did you guess? And this is very important, that she had what is called asynchronous growth of follicles, because of which one follicle became dominant and the others were lagging behind because she did not receive any type of pre-treatment. And the second commonest thing I ask her, that was your pickup done on a Sunday or a Monday sometimes? Oh no, they did it on a Monday, although the follicles were 18 on Friday. So many a times, to avoid a weekend work or a Sunday pickup, the egg pickup might be postponed or preponed, and that is how the triggering also might cause an adverse outcome in the cycle. So if you go into all these details, you'll definitely be able to do a better job for 80% of these patients. Western studies apart, because a lot of people argue you pick up human reproduction, they always start with 150. Well, we have studies showing that the Indian fertility is a little different from white Caucasian fertility. And let's look at our own studies, where clearly we know that 225 should be the starting dose across all spectrums, except maybe a severe thin lean PCO patient. Otherwise, you should be using at least 225, even 300 for all your potential normal responders. And again, what are the polymorphisms that we commonly see in India? And we have this paper from Udumadi in 2023 showing you all the various polymorphisms where you will need to begin with a higher dose of FSH or add LH right from the beginning of stimulation. Pre-treatment most important. Don't be tempted to rush into starting an FSH if she walks in late day 2 or day 3 or late day 3 or early day 4 just because you don't want to miss that month, especially if she is a poor responder. Because remember, a lot of these poor responders have what do you call, they are in a stage of desynchrony. Now what do we mean by desynchronized cycle? Because they have low inhibin levels in the luteal phase, the follicular recruitment begins in the late luteal phase of the previous cycle, and this becomes a dominant follicle even when she menstruates. So then when you start stimulation on day 2, this follicle races ahead and is already 16, 17 on day 7, and all the other follicles which are newly recruited are lagging behind at 12 to 14. So you have to recognize this group of patients. The classic clue is on day 2, they will have low AMH, but they have normal FSH. Now how did the FSH normalize? Because E2 already started coming from that late luteal selected dominant follicle, which gave a negative feedback and gave you a reduced FSH level. So if you have a high E2 on day 2, please be wary, do not begin stimulation immediately or you will end up with an asynchronous cohort. And this is how you can see the late luteal and the early follicular phases merge with each other and give you a dominant follicle before it is supposed to have been recruited. So for antagonist cycles, pre-treatment is mandatory. Luteal estradiol works the best, is the easiest, the most economical. You have to begin estradiol valerate BD 4 milligrams a day from day 21 to day 25 of the luteal phase to ensure that that selection of the dominant follicle does not happen till you don't begin your exogenous gonadotropins. If you just want to tide over a weekend for scheduling purposes, even the antagonist works well. Just give the antagonist on days 2, 3, 4. This will suppress any dominant follicle which has come up. And day 5 you begin your regular stimulation with a little bit of LH and you will get a beautiful response. Of course, personally, I still feel that the use of the agonist gives me a better outcome in poor responders across all Poseidons 1, 2, 3, 4. Because you will not have any selection of the dominant follicle, you will not have any premature LH surges, you have the best synchrony ever. Because I remember when I started 36 years ago, we had only the agonist and we had never heard of this term called asynchrony. It is only when we switched to the antagonist protocol that we started getting follicular asynchrony in a lot of patients. So you will definitely have better outcomes. And the most important, now that we are trying to do more and more fresh transfers as per a lot of recent RCTs, especially in poor responders and women above the age of 35, remember there are enough studies to show that the agonist gives you a better endometrial receptivity for a fresh transfer as compared to the antagonist. So of course we had Huang study in 2018 and you can see Poseidon group 3, your young patients with a low AMH do better with the agonist with a live birth rate of 30% as against 16.7% with the conventional antagonist. Trigger, again, it is advisable. There is a European consensus. The recent ESHRE guidelines also say that maybe a dual trigger, that is a combination of HCG with the agonist, will give you a better outcome in poor responders as far as number of metaphase 2s are concerned. And you can see even the live birth rate almost doubles from 14.5 to 26.9%. What about 3 and 4? Now 3 and 4 you have time, you know she has a poor reserve, you know she's failed a cycle. So you have to give more importance to oocyte competence. We know she's going to give you only that many eggs. She's going to give you 3, 4 or 5 oocytes. And you have to remember that everything about an oocyte is not genetic competency, as so many people just keep saying that PGT is probably the answer to finding out which is the best embryo, and I'll show you evidence why it's not. We have to remember that the mitochondrial DNA is susceptible to aging, and you have to make sure that you use your supplements judiciously. So don't use a preparation which gives you 20 micronutrients, but look at the evidence, and the evidence so far is only for androgens, for coenzyme Q and its active form ubiquinol, and for the use of growth hormone. So of course, personally, I like to use a combination of ubiquinol, resveratrol, but you have to stop it in time because resveratrol can work both ways. So generally 60 days of pre-treatment. And if you are fond of the others, you could use some bit of leucine and glutathione and some of your anti-aging and antioxidants, but don't go beyond this and just overload her with so many supplements that she's already fed up of the IVF cycle. Androgens, we went back and forth, but most of the meta-analysis agree that testosterone pre-treatment is useful. And the same author, Polizos, and I keep meeting him and bumping into him. Last Sunday we were together again at Goa. And he in 2022 showed testosterone is good. Then subsequently he did a T-transport trial where he showed testosterone doesn't work. Personally, I feel the T-transport trial had a very low dose of testosterone for 2 months. So what I prefer to give is 2 actuations of the gel beginning from day 6 of the preceding cycle until day 2 of the stimulation cycle. That's about 20 to 21 days, and that usually suffices, especially in the Poseidon group 4. LH supplementation, again we have been debating for 30 years, thanks to all the pharma wars, that first it was HMG, then they said no, purified FSH, then they said highly purified, then rec FSH, then filled by mass FSH, then again they started adding LH, then we had recombinant LH, then we had HCG driven LH activity, but now we again conclude that yes, LH is required, and not from day 7, and I'll show you why. You have to add it right from the beginning. And for all women above the age of 35, all your hypo responders who are probably polymorphism carriers and have stagnant follicles after day 7, all patients with hypo, remember hypogonadotropic hypogonadism is the best patient to get. So please don't start her on 225 HMG for 5 days and say no response, go for egg donation. She won't. She needs a starting dose of 300. So the minimum starting dose for all your hypogonadotropic hypogonadism patients is 300 of FSH and 300 of LH right from the beginning of stimulation. And adding back on day 7, you can see this study from 2021. Early follicular HMG means giving LH right from day 2 versus adding LH from day 7. Live birth rate drops from 22% to 12% in Poseidon 3 and 4. But since the lecture given to me is what's new and what I feel is going to be exciting, and that is early triggering for some women of advanced maternal age. And we have this paper by Fatemi in 2024, where he does a modified natural cycle, means you add FSH and antagonist when the natural lead follicle is about 10 millimeters in diameter, usual triggering and oocyte retrieval criteria, but he compared various groups. So triggering conventionally at more than 17 mm, triggering at follicle size between 15 to 17, 13 to 15 and 10 to 13, and most of us would imagine that 10 to 13 would give the worst outcome and only an immature oocyte, but if you actually look at the blastulation rate is the highest from follicles in the range of 10 to 13 millimeters. Now don't go tomorrow, and this is not the take home message. Remember what I said, it's a modified natural cycle where you have only one oocyte, and it's for women of advanced maternal age who have not done well with the conventional triggering. So what he showed that the chance of getting a metaphase 2 oocyte is the same. Similar blastulation rates were seen, but live births were seen even from oocytes retrieved from follicles as small as 12 millimeters. So we need to change our conventional triggering criteria, again bringing us back to individualization of each and every patient. How many of you knew that after the age of 35, MVP, vaginally administered micronized progesterone, is not absorbed too effectively? So even there you have to be individualized, that for an above 35 age group you have to add some injectable progesterone and not just give vaginal progesterone, because it's not going to be the same. Dual stimulation, it came with a bang, and we still have so many clinics doing dual stimulation, so-called follicular followed by luteal, which actually was just follicular followed by follicular, because we were giving an agonist trigger and we were just doing another follicular phase and calling it a luteal phase stimulation. So the better way to do it, if at all you have a patient from overseas who is only with you for 4 to 5 weeks and not able to stay for a conventional 2 cycles, then maybe this is the correct way. The first stimulation begins in the luteal phase. You start document ovulation, begin FSH or HMG, add the antagonist at 14 mm as usual, give an agonist trigger, do a retrieval, freeze those embryos, wait for a menstruation, then do a conventional follicular phase stimulation, this time with an HCG trigger, and do a fresh transfer using whichever embryos were of better quality. And this is a very recent study published by Annalisa Raka and Polizos, and it is going to be presented at London ESHRE, the first study reports, but I spoke to Polizos and he said it's working much better than the conventional dual stimulation. Again, they agree there is no other benefit except if time is of essence and patient can't stay for 2 to 3 months to do 2 conventional cycles, then this is the correct way of doing a luteal phase followed by a follicular phase dual stimulation. Just one slide on what was said at Paris ESHRE, which I am really happy about. The first, letrozole and clomiphene add-ons in poor, normal or high responders not recommended. And for those of you who know me since 35 years, you know I never did any hormonal monitoring during an IVF cycle. I never believed in LH levels, E2 levels, progesterone levels, FSH levels and what have you, which is being checked every alternate day in so many clinics. Finally, ESHRE has validated that hormonal monitoring during stimulation is not required. If you have a good ultrasound, you do not need to do any hormonal monitoring for the patient. So the only hormones we monitor, AMH before we start, beta HCG to confirm pregnancy, and one serum progesterone on the day of HCG if I am contemplating a fresh embryo transfer. Laboratory aspects for poor responders, again, should you do ICSI for all, PGT for all, and clearly there is no evidence anywhere in literature that ICSI is better if you get only 3 eggs or ICSI is better if she is 38 years old. So please abandon that practice. You have to continue with your conventional IVF. You need not do ICSI for all, especially in view of what Valerie Baker showed from John Hopkins. They followed up 2 lakh infants born out of IVF and ICSI and showed that when you do ICSI in the absence of a male factor, you are increasing the risk of birth defects by 30%. What we do in our lab for all Poseidon 4s is activation. Calcium ionophore activation works beautifully. After you inject the oocyte, put it into calcium ionophore activation media for 15 minutes and then transfer it back to bicarb buffered media. The most important paper all of you should read before you recommend PGT just because she is 40-year-old. You know how scared the patient is made to believe, oh, you are 40, if you don't do PGT, you will have a chromosomally abnormal baby, you will have a Down syndrome baby. You know what I found out just about a month ago, because every morning we have video calls with patients from the US who have failed 2 or 3 cycles, and as you must have guessed, all were PGT cycles. And then they say, how can you not do PGT? I say, I will not do PGT, I will do day 3 transfer, I will do fresh transfer. Are you from Adam Jamana? Means what are you talking? Everybody in US does PGT. I said, you are such a smart person, just open ChatGPT and type a good prompt. What is my risk of a chromosomal anomaly at age 40? And I said, before you do that, tell me what do you think it is? And she said, oh, it must be 50%. And you know what the truth is? At 40, it's 1 in 80. And at 39, it is 1 in 200. And at 38, it is 1 in 300. And yet these patients are made to believe that PGT is the final thing. If you don't do PGT, you will have an abnormal baby. So thankfully, the American guidelines 2024 clearly said value as routine screening remains unclear, and they have put down the indications for very specific populations like Rishikesh pointed out. Please don't do it in a first cycle. Only for very advanced, say a 42-year-old with a history of 2 or 3 pregnancy losses, or maybe 3 or 4 recurrent implantation failures which are unexplained. And maybe, of course, all of you know this slide, that a small biopsy from one place cannot represent the entire embryo. Many lawsuits have been filed in the US by patients who now did their research and found out that all aneuploid embryos need not be abnormal babies, and my embryos were discarded. So I have lost my last chance of having a baby, and that is why lawsuits are being filed. But this is the paper which I was mentioning, and that is opening the black box of PGT. That despite your assurance to the patient that I am putting a euploid embryo, so you will not have a miscarriage, either she doesn't get pregnant only because of the damage, or she again has a miscarriage. Despite putting a euploid embryo and having a miscarriage is the most difficult patient to face when she comes back to you. So Laura Renzi, Alvigi and Ubaldi did this study where they analyzed 1,600 items, 430 research papers, all the RCTs on PGT. They analyzed all the embryonic, maternal, paternal clinical laboratory factors and clearly concluded that just by telling the patient you are putting in a euploid blastocyst, this will not compensate for advanced maternal age if she is a case of recurrent implantation failure, or if the morphological embryo, quality of the embryo was not good to begin with. So if it was not a AA to start with, you are unlikely to get a pregnancy if it was a BC or a BB, because the morphological grading is the #1 predictor of success in an IVF. What about the future? We hear so much about intra-ovarian PRPs. Again, you can see here, before PRP, after PRP, Kakiroglu's first study came in 2022. Again, seems to be benefiting mainly the under 38 years age group. You can see where you have almost a 34% chance of live birth as per this paper. But again, the European and American guidelines are very clear that intra-ovarian PRP is considered experimental, and as of today we have only one RCT, and that is the PROVA trial from Sweden, where they clearly showed that intra-ovarian PRP does not have any beneficial effect for the patient. So when you finally come down to RCT and evidence-based medicine, we really need to rethink. But yes, if you're doing it at the time of an egg retrieval, as a lot of people tend to do, where you're not adding on too much of invasive stuff, maybe for a under 40 age group with an AMH which is not absolutely zero, and where you at least see 1 or 2 antral follicles, maybe you could inject a little PRP and hope that something works. Moving on from poor responders, what's new for PCO? And this, of course, all of us are very excited about the weight loss drugs. Personally, I have been using a lot of it for PCO patients, and it's just like magic, because if you have a 130 kilo patient who comes to you, we tell her, okay, we'll freeze your eggs. If she's 37 and doesn't want to waste time, we do the egg retrieval, make the embryos, freeze them. Then I tell them to go back 3 to 6 months on a Munjaro. They come back, say 100 or 95, and the outcomes are much better, at least from the obstetric and perinatal point of view. So current consensus, of course, we know every conference now you will start hearing more and more about these drugs for obese PCO patients. And apparently inadvertent exposure in early pregnancy doesn't seem to be harmful. And you can see Salamoon actually did a trial where he combined it with metformin and showed a higher cumulative pregnancy rate, natural pregnancy rate, over 12 months. So obviously it was considered to be safe, but like with any other molecule, we need more studies to be sure of the long-term and short-term neonatal and infant effects. PCO is now almost a no-brainer for us. There were 20 years ago, we used to be scared when we saw that thin, lean PCOS walk into the clinic and dream and have nightmares of ascites and pleural effusion. But now, thanks to the antagonist protocol, the agonist trigger, and the freeze-all policy, we no longer see that. But what's new? What's new for the PCO patients? And here we have wonderful new AI-based nomograms which will now be available. In fact, they're already available, so it's not just the future, to decide the initial starting dose in a PCO patient. And why? Because follicular asynchrony is not limited to poor responders. Many a times, even in your PCO patients, you find 2 or 3 follicles have become 19 and the others are still lagging behind 15 to 16 mm. And that is because maybe your starting dose was too high. So for example, this algorithm tells us that BMI 28, basal FSH 6, basal LH 8, AMH 8 and AFC 24, the predicted initial starting dose is 125, and we should not give her 225 or anything more, otherwise you will end up with asynchronous follicular growth, as Soldatovic showed in 2025. And you can see when you use the algorithm, you bring down the incidence of early follicular and late follicular asynchrony. So this is one fine tuning which we need here. The second interesting aspect is, of course, PPOS, which we know can be used in PCO patients because you will be doing a freeze-all. But a word of caution here, that avoid PPOS in the above 36 years age group, because somehow there is a higher risk of aneuploidy if you are doing PGT in that age group because of the inadvertent exposure of the oocytes to synthetic progesterones in the follicular phase. So of course we have a lot of studies. In fact, Chen showed a higher clinical pregnancy rate with PPOS as compared to the short protocol. And one more new advance we have is delayed triggering. So I told you about early triggering in women of advanced maternal age, and now there is a concept of delayed triggering PCOS to reduce the risk of early pregnancy loss. So those of you who attended ISAR last year, Itakura was there in person and he showed this wonderful new protocol. FSH 150 from day 2, HMG, switch to HMG 150 from day 7, antagonist not to be added at 14 mm but to be added at 18 mm, agonist trigger not at 17-18 mm but when the largest follicle is more than 24 mm, 1 tablet of letrozole if your E2 level is between 4 and 5000, 2 tablets of letrozole on the day of HCG if your E2 is above 5000. And look at the outcomes with this modified COS. The live birth rate increased from 18, 27 and 25 to 36%. Miscarriage is reduced and cumulative live birth rate. So you had many more high mitochondrial integrity embryos for freezing as compared to conventional antag and triggering at 17 mm. Cumulative live birth rate using all the embryos went up from 30, 38 and 37 to a wonderful 57%. Finally, of course, the most important change which needs to come in IVF is we have to switch more and more to natural cycle IVF. So, I mean FET cycles, and I am not saying stop HRT FET. HRT FET will have a role to play because we are humans and we cannot work 365 days. You cannot manipulate or schedule a transfer too much in a true natural cycle transfer. But let's recap how the story began, because personally I am guilty of being one of the biggest advocates of Freeze-All for All about 10 to 15 years ago. I'm sure a lot of you heard my lectures in those days, but now it's again individualizing. So high responders, these are the patients who will require Freeze-All for All. So you have to restrict Freeze-All for All just for these patients. And why shouldn't you be doing it for all? Because we now have evidence of a higher risk of PIH, macrosomia, placenta accreta in FET cycles and Freeze-All cycles as compared to fresh transfers. Also, those of you who attended ASRM 2018 would remember Rob Norman's paper where he showed once and for all that when you compare non-PCOS patients fresh versus frozen, the outcomes are absolutely the same. And subsequently, we have a lot of studies, Barnard in 2024, again showing singleton live birth rate with frozen 51, with fresh 48.8, no difference between fresh and frozen, and the numbers are huge. 2,300 patients in the FET arm, 6,300 patients in the fresh arm. And another study by Plosker 2024 again showing fresh versus Freeze-All. So just the number of papers would show you that how much of rejuvenation there is in interest in doing more and more fresh transfers. But again, a lot of you would argue, okay, what is the downside of doing only Freeze-All? And that is where Wong's paper is very important, that a lot of embryos prefer the fresh endometrium. So he did a wonderful study comparing one fresh followed by a frozen versus frozen followed by frozen. And a lot of us would imagine that maybe the success rates were same, but you can see the blue line, the live birth rate with fresh followed by frozen, which is what we used to do in the days of slow freezing, much higher than FET followed by FET. A lot of us feel poor responders should have Freeze-All. There is absolutely no logic. When there are less than 10 oocytes, you do not have supraphysiologic estradiol levels, you do not have impaired endometrial receptivity, and this is one of the largest studies by V in 2025, clearly showing that there is live birth rate of 40% with fresh transfers in poor prognosis women as against 32% with Freeze-All. Cumulative live birth rate also better with fresh transfers. So also women above the age of 35 where PGT is not indicated, fresh transfers 24%, frozen transfers 19.7%. So what then are the criteria for doing fresh ET? Of course, less than 10 oocytes is what we follow. Endometrium is good, triple line and receptive, and your serum progesterone, as I told you earlier, on the day of HCG is between 0.5 and 1.5. Endometrial preparation, of course, we had this huge list of types of preparation of the endometrium, and we are familiar with how to do a fresh transfer, how to do a HRT FET transfer, true natural cycle and modified natural cycle. But why is it time to go back to natural cycle transfers? One, I already told you, increased PIH, double the risk of PIH and macrosomia with HRT FET. Unfortunately, we don't have our Indian data, at least I don't have, because I don't do obstetrics, so I don't know if this is really true. But there seems to be a lot of evidence of PIH being increased, because remember that the corpus luteum doesn't produce only progesterone. So we think when we pump in all types of progesterone, we are replacing everything that the corpus luteum gives, but that's not true. And the absence of a corpus luteum will increase theoretically and practically the risk of PIH. Second, a lot of you would agree that when you saw her the first time on her natural cycle, her endometrium was 9.6, and you have a photograph documenting the same, but you put her on 12 milligrams of estradiol valerate in your HRT FET cycle, and she just doesn't go beyond 7.5 or 8. And the third most important thing, if you really, in these competing times with so many IVF centers, you have to make sure that every patient who comes to you comes back if she fails. And if you go into the reason for dropout, most of us assume it's the money and it's the financial part, but if you actually speak to the woman, it is the amount of medication we give her after embryo transfer. And look at the typical prescription that a lot of clinics tend to give. Estradiol, aspirin, L-arginine, heparin, intramuscular, subcute, gel, capsule, sildenafil, thymosin, HCG, and even the agonist or antagonist in some cases. So just imagine the amount of burden on the patient. Number one reason for dropout in my experience is the HRT FET protocol, and not the stimulation, not the anesthesia, and not the egg retrieval. And this is probably from a consideration of a practical point of view of making sure your cycle numbers remain good, is to try and keep things simple for the patient. So natural cycle is so easy to do. If you are a good transvaginal ultrasound expert, which all of you are, you just have to monitor follicular study, find out when she ovulates, and time it so easily at ovulation plus 5 days for a blastocyst or plus 3 days for a day 3 embryo transfer. Then you would argue, what about the anovulatory patients? Just do the IUI protocol I showed you, sequential letrozole HMG with the antagonist, and clearly you can see the letrozole FET group, 8,000 patients in this study, increase in the live birth rate with an odds ratio of 1.37, significant reduction in PIH and macrosomia because you have a functioning corpus luteum. So again, very easy. HCG plus 7 days for a blastocyst transfer, HCG plus 5 days for a day 3 transfer. Now for those of you who will argue that I can't work 365 days, there is not one. All of you are aware that you can give an HCG trigger at 17, 18 and prepone transfer by say a day or two. But there are so many ways of changing the day of transfer. So of course giving a trigger is the commonest, but triggering time. Now this is a beautiful paper where they compared triggering between 13 to 16 mm, triggering at 16 to 19 mm, and triggering conventionally at 19 to 22. Means you can trigger her at 14 mm and prepone the date of transfer by 3, 4 or even 5 days without affecting the clinical pregnancy rate. Or you just add the antagonist. So you give her HMG 150 with the antagonist, so she will not have an ovulation till you don't trigger her, and you can postpone the weekend to a Monday or Tuesday. And the most dramatic is Ribeiro's study, which was presented at Copenhagen this in ESHRE, and that is you don't even need to trigger. So you just check on day 9, day 10, day 11, the minute the endometrium is ready, irrespective of follicular size, just begin the progesterone and schedule your transfer. And then you would argue, what about the corpus luteum you've been talking about? Just giving exogenous progesterone, even if the follicle is 12, 13 millimeters, will make sure that you get a functioning corpus luteum. And that is the beauty of this protocol. You can see clinical pregnancy rates up to 57% with natural proliferative phase. And you can see the live birth, this is the most important paper which will convince all of you that the only way forward in 2026 is modified natural cycle transfers. Molinaro did a 5-year retrospective study and showed it's not just reducing the burden of medication, but a 30% increase in live birth rate with modified natural cycle. So our own experience, September, November 2025, we started doing a lot of fresh transfers for poor prognosis patients who have failed 2 or 3 cycles in the past, 37% pregnancy rate, and true natural FET for patients with 2 previous failures with HRT FET, again 52% pregnancy rate in this difficult group of patients. So you have Lot of advantages of doing this. Patient will come back for more cycles, and it's not just more cycles, you're definitely improving the pregnancy rate as well. The drawbacks, of course, you need lot of visits for monitoring ovulation. There will be a 15% cancellation because somehow in that month she doesn't ovulate or you miss the day, and therefore there may be a little bit of turbulence there. So HRT, FET definitely here to stay, but again individualization. So patients with irregular cycles, a donor or surrogate arrangements where the embryos are not ready, and where clinic operations make intensive monitoring impractical, all these are areas where you still have to do your HRT, FET. We heard a lot of discussion in the RIF lecture. So what really works for me is subendometrial PRP. I'm sure all of you are also doing it because you can deliver a larger volume of activated PRP at the place where it is required and not just in the uterine cavity. And this was the pilot study which showed a clinical pregnancy rate of 42%. And they were of course doing it in the previous cycle, means you do it on day 25, then she menstruates, then you give her estrogen and then do your regular cycle. Now there are studies that you can even inject it in the transfer cycle. So once she's on estradiol valerate, on day 10 or day 11 you can do a hysteroscopic PRP. You will not traumatize the endometrium, and the studies have shown you get a 55% increase in endometrial thickness. Pregnancy outcomes, you can see live birth rates up to almost 38% with hysteroscopic injection of PRP. Again, finally, it's what you get, and this is what we have. We have not just applied it to thin endometrium, but also for some patients of RIF, and you can see how pregnancy, 30% pregnancy rate in these two difficult groups of patients. And since of course it's Nitin's conference too, endometriosis, all of you know that please don't operate unnecessary where fertility is an issue. And of course we know Velasco's indications of where you should be operating. But from the IVF point of view, I wanted to show you this slide. This is what we follow. Endometriosis with infertility, where you should be operating and where you should be doing IVF and embryo freezing before doing surgery for any of these patients. Egg freezing, very, very successful. Remember, prevention is better than cure. I'm sure all of you are doing it. But the reason I put these slides is to show you how successful it is. You have a lot of studies by Sanchez, Anna Cobo, and all the authorities in embryology clearly showing that frozen oocytes give you the same outcomes as fresh IVF and embryo transfer. Do we have time or should I? It's okay? Yeah, fine. So for the gynac, of course, you have to remember that a lot of these girls are not sexually active. So as a gynac, before you refer for egg freezing, please get into the hymen thing and whether they need a hymenectomy, and counsel them that all the interventions will be transvaginal. Also explain the success rates and do some evidence-based counseling. For example, we use these two slides where you can see under 35 patient, the live birth rate expected would be around, depending on the AMH levels and number of oocytes and so on, what should she expect. So on an average, we tell her that if you have around 10 metaphase 2s frozen, you are under 35, you would have a 65% chance of pregnancy in the future. If you have around 20 metaphase 2s, maybe you will have a 85% chance. What's new for male infertility? Again, use your supplements very judiciously, and we have Esteves and Humaydan study clearly showing 3 months lifestyle, weight loss if it's an obese man, antioxidants, CoQ10, omega-3 and so on will reduce the sperm DNA fragmentation in these patients and help you in patients who have failed 2 or 3 cycles of ICSI in the past. So when you have a patient with high sperm DNA fragmentation, there are 2 approaches you can do. One is the use of microfluidics and the Zymot cell sorter. And the second, what we do very commonly is use testicular sperm instead of ejaculated sperm if there are 2 or 3 ICSI failures in the past. And you will see a huge reduction in the various outcomes. The miscarriages go down, the live birth rates go up when there is elevated sperm DNA fragmentation in these patients. What about gonadotropins for the male? Just as you have Poseidon in the female, you now have gonadotropins for the male with the Aphrodite classification. Of course, only 3 categories benefit. One is the hypo man, where a combination of FSH and HCG is useful. The second is the patient where there is no demonstrated cause, where a semen analysis reveals a few abnormalities and you do ICSI and you don't get an outcome, maybe FSH monotherapy for 3 months, and FSH and HCG again for a few cases where there are altered semen parameters, normal FSH and reduced testosterone levels. Very important, you know, we take it for granted that paternal age has nothing to do with fertility. Very important to counsel the patient, and it's good that the ART Act has put an upper bar at 55, because now there are a lot of studies showing increased risk of autism and even schizophrenia, bipolar and so on in the children if the paternal age is above 50 at the time of conception. Finally, of course, please use your add-ons, and I think a lot of this was covered in the morning panel. But the only thing which really works the best in recurrent implantation failure is hysteroscopy, which is mandatory. Rest, everything discussed in detail in the morning. So for all of you gynecologists, what is important? When to refer for IVF or ICSI, very important. 12 months of infertility if the woman is young, 6 months if she is about 35. Earlier referral if she has very low MH, very severe endometriosis, severe PCOS and so on. Please counsel them about realistic success rates. Please discuss the need for recurrent IVF cycles. So we were just discussing with Polizos last Sunday that in Spain, when do you call it a day? At how many number of cycles do you tell the patient, okay, now you should stop? The world record is 33 cycles, 33 egg retrievals in a woman from Qatar who finally didn't conceive in the 33 retrievals and had to take an egg donor. But he said that generally in Spain we tell 3 to 6 cycles. So I said, why 3 to 6? He said medically 3, because if 3 don't work in a good clinic, you need some change, major change in the form of a third party or something else to be done. 6 because insurance covers 6 cycles in Spain. So 3 to 6 is what they generally recommend for these patients. So of course the gynecologist should be aware that where we are with success rates, and of course we are doing much better than we were 30 years ago. And you must be in close touch with the IVF center throughout your patient's treatment, because she's going to come back to you for obstetrics and you are the one who's referred her, so you need to know that everything is done in the correct manner. What is being done? Have things been changed? Is she doing the same thing again and again, and so on. So finally, to end, of course, the future is going to be personalized ovarian stimulation. So we know that we cannot have one standard protocol for all. Vitrification, we now have ultra rapid freezing for oocytes, and blastocysts it takes just 1 minute to do instead of the conventional 10 to 15 minutes, and with a 98% recovery of survival of the oocytes and embryos. And of course, we already heard the wonderful talk on artificial intelligence. So when you have a failed IVF, change and change. Don't do the same thing again and again. Every aspect needs to be changed. So thank you once again, Mohit, Rupa, Shrutika, Sheetal, Nitin, Bela, Jayanti. I'm sorry if I forgot any names. Thank you, ladies and gentlemen.
Thank you so much, Jatin Shah sir. It was an amazing lecture, and so we can see the zeal to teach, the dedication towards IVF. That's how you do more than 2,000 IVF cycles daily. I request our chairpersons to please felicitate our orator.
Well, Jatin, you're an encyclopedia. I put it that way. Well, ladies and gentlemen, one thing have you noticed? His name doesn't figure in any society president. No Moggs, no Foxy, no ISO, no XC anywhere. It is all work and work for this gentleman.
I
Anyway,
request
thank you so
Dr.
very
Nitin
much.
Shah sir and Dr. Saraugi sir to please join the felicitation. Thank you so much. I request our President Dr. Nitin Shah sir and Saraugi sir to please felicitate our chairpersons. Thank you so much. And with that, we go to our next session. And for chairing the next session, I would call upon Dr. Rashmi Saraugi, Madam. She is a senior obstetrician gynecologist from the western suburbs. Welcome, ma'am. Our next chairperson is Dr. S.N. Agarwal, sir. He is a senior practicing gynecologist from Mira Bhainder. And our third chairperson is Dr. Anurag Bhate, sir, President-elect of AFG and gynec endoscopic surgeon. Welcome, sir. I request the chairpersons to please call upon our speakers.
So good evening, welcome all. Our first speaker is Dr. Mohit Sarogi, convener for this program. He is the director IRIS IVF and Endoscopy Center, Sarogi Hospital, an alumni from State GS Medical Hospital and KM Hospital, gold medalist and topper. Former assistant professor, Department of OBGYN, JJ Group of Hospitals, fellow ICOG in Fertility with Foxy, managing 5 IVF centers in India and 1 in Africa, number of international index journal publications, national journal publications, and additional training of infertility in Europe. The stage is yours, Dr. Mohit.
Thank you. So after such a wonderful talk by Sir, talking about what is new and what are the advances in IVF, I will go back to the basics, the roots, what is the actual running of an IVF center, how does it work? And I believe that this lecture would be useful for people who've not really seen what goes on behind the scenes and what happens inside an IVF lab. Now, as children, we've often read the book, The Charlie and the Chocolate Factory, where we want to be Willy Wonka, we want to own this magical chocolate factory, and we want to be in charge of everything else. And when I was a child, I did too. But then life happened. And I grew up, as we all do, but I got to do something better. I got to run an IVF lab. And this is literally a factory where we create life. And there can't be any greater joy or satisfaction than this. And just like any other factory in the world, an IVF lab has its own machinery, its own manpower, its own QC, QA protocols, and its own SOPs in place. And here the stakes are much higher. And the returns are also far more rewarding. Just like any other factory, the better we maintain and run our lab, the better the IVF results will be. And this translates through a live birth through an IVF cycle. Today, it's going to be my proud honor to walk you through this journey of creating life. Now, as clinicians, we understand that the IVF lab is a biological extension of the female reproductive tract. Our primary objective here is to minimize external stressors, that is specifically VOCs, light toxicities, and pH fluctuations. The end objective here is to maximize cumulative pregnancy rates per egg retrieval, and to achieve this, we must focus on sterile chain of events of custody and environmental homeostasis. Now let's go back to how the process really works. Chapter 1, 13 days to pick up. Now here the couple comes to us, the couple's already been counseled for ICSI, documentation has been verified, investigations have been done. And the couple has been given antioxidants for a variable duration of time, depends on couple to couple. The lady then comes in on the second day of her period. Firstly, we do a transvaginal sonography. The purpose is to rule out whether there's a simple ovarian cyst or not, to count the antral follicle count, and to decide the dosage of gonadotropins to be given to the lady. Then the patient is stimulated either using an agonist, which is a long protocol, or an antagonist, which is a short protocol. The stimulation can be with either recombinant FSH injections or with HMG injections, or sometimes a combination, and the duration of stimulation usually ranges from 10 to 14 days depending on the patient. The trigger is given somewhere around day 12, and the trigger can be either an agonist trigger or HCG trigger, or sometimes a dual trigger, as in cases of poor responders. Now when we are doing a follicle monitoring usually starts around the 4th day and is done serially every alternate day. And we correlate the number of follicles and the size of the follicles with the day of stimulation. A good stimulation usually would show a synchronous growth of follicles. If you look at this video or this image, you'll realize all the follicles are almost uniform in size. Usually the follicle size is around 14 millimeters around day 7, around 16 millimeters around day 8, and increases by 2 millimeters per day. And when the majority follicles are around 18 to 20 millimeters in size, that is when the trigger happens. The timing of an ovum pickup is usually between 34 to 36 hours. For poor responders, we do an early pickup, that is at 34 hours. For normal responders, it's around 35 to 36 hours. And the pickup is usually performed in a sterile IVF OT with strict aseptic precautions. Now let's come down to the IVF OT. IVF OT is the workstation where the surgical procedure is performed. That is the egg retrieval and the embryo transfer. An IVF OT has to be different from your obstetric OT. It's got to be very different from your laparoscopy OT. Not only in the materials used, because in IVF OT usually you're going to use either a tile, you're going to use ACP sheets, you're going to use a puff panel, because these are relatively VOC free. This is in contradiction to a normal OT where other materials can also be used. Secondly, in a normal OT, very often we use formalin chambers for laparoscopy cases. You can use glutaraldehyde. You very often use phenyl for cleaning the floors, and this cannot work in an IVF OT. It will simply elevate the VOCs and reduce your results. So in IVF OTs, the material used is very specific. It's ACP sheets, it's tiles, it's going to be puff panels, and the cleaning is usually done using either autoclaved water or distilled water. And it's a surface cleaning. So although structurally the same, the material used is different, and the equipment used is different. Now this is the heart of a good pickup, your ultrasound machine. The better the resolution, the better the visualization, the better the egg retrieval is likely to be. If you can see, this is going to be your TVS probe, a simple transvaginal probe, and to this is attached a biopsy guide through which we can pass the needle, which helps in ovum pickup. Now in cases where batch ovum pickups is done, a day before the procedure, the lab and the OT is thoroughly cleaned, all the equipment connection is double checked, power supply is checked, and you have to remove the culture media. So one day before doing the procedure, culture media, hippies and oil has to be removed in sterile test tubes and put in a box CO2 incubator for calibration so that it can be used the next day. So actual IVF preparation begins a day before. On the day of the procedure, the patient is asked to get admitted with 5 hours of fasting and without the use of any cosmetics or deodorants to prevent elevation of VOCs. All lab equipment is double checked to be working properly, including calibration of the equipment. A OPO procedure is performed in TIVA or sedation. The time required is usually about 10 to 15 minutes. The patient is given a traditional lithotomy position, and cleaning of the private parts is usually done using distilled water or normal saline. And the TVS probe is then covered with a sterile probe cover and a biopsy guide. Can you play the video? Yeah. No, previous video. Yeah, this one. So I'm going to try and show you with the help of a video what a pickup needle really looks like. Go down and play. Thank you. So the longest needle in the world is actually an ovum pickup needle. It's about 330 millimeters long. And it comes with a sterile sheath on top. You remove that, this is what the needle looks like. It's attached to tubules, and this is attached to a stopcock which fits into a sterile test tube. The needle goes into the follicle, the fluid is aspirated in the tubes, and it eventually comes out into the test tube. Okay, next. Now while doing an egg collection procedure in the lab, this is actually what it looks like. So this is a vision. Now the needle is jabbed into the middle of the follicle, and you can see that the follicle is collapsing. The needle is placed right in the middle. As the follicle collapses, the follicular fluid gets collected into sterile test tubes, which are eventually passed on in the lab to the team of embryologists who are then going to scan it and look for the oocytes, the oocyte cumulus complex. You have to wait till the follicle completely collapses, and then in the end a curettage is done so as to make sure that any OCC which may be stuck to the wall gets removed as well. Alright, the video. Now while this is going on, this is a video which shows that the follicular fluid traditionally gets collected into sterile tubes. These tubes are placed in a warmer, okay, which is preheated at 37 degrees C because that is your body temperature. So follicular fluid gets aspirated into test tubes which are also heated at 37 degrees C, and then these are passed on inside the lab to the team of embryologists. After an egg retrieval has been done, this is traditionally what an ovary would look like. You can see that there are multiple hemorrhagic cysts or corpus luteum which have been left behind, and this suggests that the pickup has been done and the pickup is complete. Now, post-egg retrieval, we grade the cumulus oocyte complex. Now, for sperm preparation, once a sample is given in a container, the sperm is usually cleaned using a double density gradient centrifugation or sometimes microfluidic sorting to isolate sperms with high DNA integrity. Now, once fertilization is to be done, you can either resort to IVF or ICSI. In cases of severe oligoasthenoteratozoospermia or OAT, ICSI remains the gold standard to bypass natural barriers to fertilization. Once we've got the oocytes, the oocytes are assessed in the lab to be either mature, that is M2 oocytes, okay, semi-mature, which is M1 oocytes, as well as GVs, which are the immature oocytes. Now, traditionally, when you look under the microscope, this is what a oocyte cumulus complex looks like, or the OCC complex. This is prior to denudation taking place. After denudation, you can make out distinctly that this is the oocyte, you can see the polar bodies, and outside the shell that you see is the zona pellucida. And if this same image were to magnify it several times over, you can see that this is the cytoplasm, the outer thin layer is the zona pellucida, and that is the polar body at the bottom. Now, sperms, play the video please sir. Sperms, when washed by double density gradient or different methods, and when looked under a video, they have rapid linear mobility, but it's random. Okay, there is no direction sense, and you can see that they're swimming all over the place. Now let's talk about the IVF lab. IVF lab is where the ICSI procedure is going to take place, and this is the equipment which forms, you know, the basic components of an IVF lab. You've got a laminar flow. A laminar flow is a sterile workstation which maintains aseptic environment where you can actually perform the ICSI and prevent contamination of the gametes, that is the oocytes as well as the sperms. You've got a CO2 incubator. The CO2 incubator is where we remove the media one day before and equilibrate it so that we can use it for the ICSI procedure the next day. Then you have the benchtop incubator. This is where the embryos are placed in individual chambers and you allow them to grow. There is a stereosome microscope in which you scan and look at the oocytes, an inverted microscope in which the ICSI is performed, and a micromanipulator which is actually used for performing the ICSI. We also require a AHU or an air handling unit. Now this is to maintain a positive pressure ventilation in the lab so that there are no contaminants and so that you will have good quality embryos coming in. So this is traditionally what a laminar flow would look like. This is a vertical hood, and from these chambers there is a curtain of positive pressure ventilation that comes through. It maintains a sterile environment where the ICSI procedure can be done. This is a box incubator where the media is equilibrated. This is a benchtop incubator in which we place the embryos post-ICSI. And this is the equipment. That's a stereosome microscope, and that is an inverted microscope. This is the microscope in which the ICSI is performed, and this is the microscope in which we scan the oocytes prior to ICSI. Now, when we talk about ICSI or ICSI, ICSI is where we artificially inject one sperm into the egg to fertilize it and create the embryos. Now here, the sperm that is selected is morphologically the best sperm which is available. So all the sperms are magnified 400 times. We know that each sperm has different parts. There's a head, neck, body, tail. Based on that, we will select a sperm where all the parts are normal, and then we are going to artificially inject that sperm into the egg. And the reason that is possible is because a sperm is significantly smaller than the egg in size. This, as we've already discussed, is done by an embryologist, is done in a laminar flow unit, and it is done using an instrument known as a micromanipulator under an inverted microscope. Can we play the video, please? So this is actually how an ICSI procedure would look like under the lab. So as we've seen that this is an oocyte, under high magnification and with the help of a holding needle, you create a negative vacuum and you hold on to the oocyte, you fix it. Now this is an injecting needle and you can see the sperm inside there. You first inject the needle in and aspirate the cytoplasm to activate the oocyte. Then this sperm is going to be injected into the egg and left right in the middle of the cytoplasm. So this is an ICSI procedure that is done. And this is how the egg and the sperm is actually fertilized. This is done repetitively. Once the ICSI is done, the vacuum is released from here, the oocyte gets dislodged, and then you can tap away the oocyte and take the next oocyte for performing the ICSI. Now let's talk about benchtop incubators. So benchtop incubators is like an artificial uterus. This is where the embryos are allowed to grow individually. Now these incubators have a humidified chamber and a tri-gas chamber. When I say tri-gas, it's a combination of 5% carbon dioxide, 5% oxygen, and 90% N2. The design of a benchtop incubator is such that it ensures when you open one chamber, it does not affect the other chamber. So all the embryos are placed in individual chambers, and by opening one chamber, the temperature fall and pH fluctuations do not affect the other embryos which have been isolated. And this stability is vital for preventing epigenetic shifts during the embryonic genomic activation. Just this thing. So as I said, once the ICSI procedure has been done, we take the embryos which are in a petri dish and they're put into individual chambers inside the benchtop incubator, and here the embryos are allowed to grow up to a day 5 stage, which is usually a blastocyst. After this comes the morphokinetic assessment of the embryos. That means we analyze how the fertilization is taking place. So just the way a newborn child has got milestones to achieve, a newly fertilized eggs has expected milestones to achieve, and if that is done, that grades as a normal or a healthy embryo. So 16 to 18 hours post ICSI, we expect a 2PN stage. 24 hours later, the embryo cleaves to form 2 equal uniform blastomeres. At 44 to 48 hours, you will have 4 equal blastomeres. At 68 hours, you'll have an 8-cell stage. On day 4, they compact and form what is known as a morula. And around day 5, they expand to form a blastocyst, which will eventually hatch, and that is eventually put back into the uterus. The key focus here is to analyze, one, that there should be no polyspermy, and to identify abnormal cleavage patterns, fragmentations, and any embryo arrest which might be taking place in the way. Now, when we talk about embryo grading, it is slightly different for cleavage stage embryos as well as for blastocysts. So for day 2 and day 3 embryos, the embryo grading is based on, one, the uniformity of the blastomere size, the absence of fragmentation, and the speed of cell division. However, for blastocysts or day 5 embryos, a Gardner stage grading is used for evaluation, and grading example 4AA is used. Now, when we talk about doing a PGTA, the procedure is performed on day 5, and it involves taking a biopsy of the trophoectoderm externally. So these are what the different stages look like. 16 to 18 hours later, you can make out that these are the 2 pronuclei that are seen. Now this is traditionally going to be around day 2 and day 3 ke beech mein. This is a day 3 embryo heading towards compaction. This is an early cavitating blastocyst, and this is a hatching blastocyst. You can make out that the blastocyst is hatching out from the zona pellucida. Now let's come now to the last part of an IVF procedure, which is actually an embryo transfer, which involves placing the embryos back inside the uterus in a healthy fashion. So embryo transfer refers to a step or process where embryos are placed into the uterus of a female with the intent of establishing pregnancy. The procedure starts by placing a Cusco speculum in the vagina to visualize the cervix. The cleaning of the cervix is done with saline solution or culture media. Then a soft transfer catheter is loaded with the embryos and handed over to the clinician after confirmation and double checking the patient's identity. And then the catheter is inserted through the cervical canal and into the uterine cavity. And the embryos are placed at the most fertile point, which is at the junction of the upper 1/3 and the lower 2/3 of the uterus. Can you play the video? So this is an animated video which shows how an embryo transfer would take place. So, no, previous, yeah. So traditionally, that will be the endometrium, the vagina. A speculum is put inside and expands to expose the cervix. This is the catheter with the embryos inside. The embryos are gently pushed in. And then the catheter is withdrawn. Now, while this is animated, how does this actually look like inside the IVF OT? Okay, can you play this video, sir? Yeah. So you can make out that this is a full bladder, half full bladder. You can make out the uterus. You can make out a beautiful endometrium with a secretory pattern. This is the cervical canal. The catheter, which is loaded with the embryos, is an echogenic catheter. You can see here. It advances through the cervix. So firstly, we remove all the cervical mucus to prevent entrapment of the embryos. And then this catheter with the embryos moves up to the internal os, and then it's advanced beyond into the middle of the uterine cavity. That is at the junction of the upper 1/3 and the lower 2/3. And here, the embryos will be gently pushed in and left there. The more delicately the procedure is done, the better our results are likely to be there. So you can see that the embryos have been pushed inside. Once the embryos are done, the key is to gently withdraw the catheter. The purpose is to prevent peristalsis, which can push the embryos out, and this will maximize the success rate. So these air droplets that you see indicates the actual placement of the embryos inside the uterus. So this is how an embryo transfer is really done. And the last part of this is vitrification or rapid freezing of embryos. So traditionally, embryo freezing or oocyte freezing was done using slow freezing techniques. That has been changed. Now what is done is vitrification. Here the embryos are placed in a cryoprotectant solution, and then they're frozen in liquid nitrogen at minus 196 degrees C rapidly. This prevents the formation of intracellular ice crystals, and it's used for both oocyte freezing and embryo freezing. The advantage of vitrification technique is that the survival rates of embryo thawing and oocyte thawing is very high. It's almost 95% for embryo thawing, and this allows for great recovery and great pregnancy rates in the future. Now this allows for backup embryo freezing for second cycles as well as social egg freezing for the patient. These are cryolocks. So these are the devices in which the embryos are loaded in the tip, and then they're dipped in minus 196 degrees C in liquid nitrogen canisters known as cryocans. And these are multiple cryolocks, as you can see from the top view, and these are how embryos are actually stored. So with that, I thank you for a very patient hearing. Thank you.
I request Nitin Shah sir to please felicitate our chairpersons. Is Dr. Saurabh Surekha there? So next, the panel discussion is on high-risk IVF pregnancy, and I call upon Dr. Saurabh Surekha to take it ahead.
We would like to call upon the moderators for the present session. Dr. Rajkumar Shah sir and Dr. Rupa Prasad ma'am. Yeah. Yeah. We would request to call upon the experts for the panel, Dr. Nikhil Datar sir. Dr. Nikhil Datar sir. Dr. Rajendra Saraugi sir. And Dr. S.N. Agarwal sir, please. Now I would like to call upon the panelists for this session. Dr. Mukesh Gupta sir. Dr. Ujjwala Neta madam. Dr. Siddesh Iyer. Dr. Raju Sahitya sir. Dr. Nishita Parekh, Dr. Ashlesha Sankhe, fine. I would like the moderators, request the moderators to take over, please, sir.
So good evening, friends. We start our panel, which is basically nothing to do with IVF, but everything as a result of IVF. And so now we are looking at pregnancies which have happened after IVF and what is the due importance that they deserve in the management. I mean, we feel IVF pregnancy is like any other pregnancy. But now this panel discussion is going to tell us how you have to broaden your ideas to look into and management of this pregnancy. So I would request Rupa to start with the discussion.
Thank you, sir. So let's see what the real difference is between an IVF and spontaneous pregnancy. Are all IVF pregnancies high risk? That's the first question. Let's see, Dr. Mukesh Gupta, what do you think? Can we say if it's an IVF pregnancy, it has got to be high risk? Everyone is scared what's going to happen to her. She'll need blood, she'll need FFP, she's going to have high BP. What do you feel?
So it may be perceived as very, very precious, but not all IVF can be high risk. But because of the pre-existing factors which have made her to go through the IVF cycle, maybe the reason why she's classified as high risk. So factors like overweight, age is on the higher side, multiple embryo transfers, frozen ET cycles, which was just now discussed at length about that, or it has been a non-natural cycle. So all those factors are predisposing her to be a high risk, which leads to preeclampsia risk, maybe risk for preterm labor, risk for IUGR, etc.
So basically why we are discussing this
Raj,
is,
I would like to add, it may not be high risk, but it is definitely high cost.
Yeah. So basically why we are discussing this is, I have been motivated to do this panel basically because I went through such a bad experience just in the last few months. One of our own patients, my own cousin, sister-in-law basically had conceived with us with the donor eggs, 42-year-old, went to Australia where she belongs to, and was supposed to deliver there. I would not like to name the place and other things as such. Till 13, she was a chronic hypertensive with a donor oocyte and had conceived after 2 losses. All other workup done for repeated pregnancy losses was not there as such. Nothing was positive as such. Despite that, everything went off well. She was chronic hypertension. She was admitted at 39th week or 38th week with hypertension and sent back home. And at 39 weeks, just 2 days before the elective section, she had an intrauterine fetal death. So this is something which bothers you a lot, that such a pregnancy, why should it be lost? So therefore, we went to the details of all these things, and now we are discussing the panel, and this is important to enlighten you as to treat every IVF pregnancy with respect, not because it's precious, but a lot of efforts have been gone through to put this pregnancy through, and this pregnancy has to be definitely rewarded with a live birth. Yes, sir.
Sir, I can see Dr. Jignesh Kansaria sir is also there. Sir, please come on stage. No, sir, please come. And Dr. Amay Purandre sir is also here. Sir, please come on stage. Actually, we went a little off schedule. We have just postponed one of our lectures and I took our panel in earlier. That is why we weren't able to welcome you. Please sit down. So let's start with the first case. Here we have a 36-year-old married since 10 years, previous 2 abortions, now 6 weeks. She's undergone ICSI because of unexplained infertility. She's come with profuse vaginal bleeding, a lot of blood, big clots. She thinks she's lost her pregnancy. The first one was a missed miscarriage at 7 weeks. Check curettage was done. Second was an ICSI conception, which again she miscarried 1 year back at 8 weeks. We have done several investigations for pregnancy wastage, found only ANA to be positive as 1:100, and her hysteroscopy was unremarkable. As of now, her vitals are present, os is closed, but still she's bleeding with small clots. The sonography shows a large subchorionic hemorrhage of 4 by 3.5 centimeters. The os is closed, cervical length is good, and the baby is alive. So she is on the usual drugs that are given post an FET conception, on estrogen, progesterone, oral progesterone, vaginal progesterone, vasodilators, ecosprin, lonopin, and a steroid at 10 milligram OD. So when we start with this, what would be the first line of management, Ujjwala ma'am?
For such cases, a strict bed rest, starting with tranexamic acid, 500 milligram TDS, and oral dihydrogesterone, progesterone.
That's already shown.
That is
She's
4
already on.
tablets stat, and then BD, twice BD can be started, or TDS, depending.
So, would you say, Amey sir, do you say that tranexamic acid is safe and can be used freely in pregnancy? We see that she's ANA positive. We are always wondering whether there could be a thrombophilia. And we are going to be stopping her thinners. So we are a little worried. Is it okay to use tranexamic acid the way we do?
Yeah, so you are in a crisis situation. You want to salvage the pregnancy. Luckily, the baby is still alive. You are seeing a subchorionic bleed. So everything is in favor of a subchorionic bleed related threatened miscarriage. If you weigh the pros against the cons or look at the benefits against the risk, you're using tranexamic acid as a salvage therapy. You're not using it as a continuous therapy. You don't have anything else to use, so maybe you should try it. There's no harm in using it. Doesn't cause any direct teratopathy to the fetus. At the same time, yes, you are saying that ANA is positive, but the titer is 1 in 100. You've not told us whether you've done an ANA blot to tell us whether it is a which type of an autoimmune problem it is. Some antibodies are pro-thrombotic, and some antibodies you could take with a pinch of salt and ignore them in spite of the ANA being positive.
So it will not only prevent the bleeding, but also will help in the reabsorption of the hematoma.
And I think the key thing here is to stop the thinners.
Yes, so that is a controversial point. We'll discuss that at length.
And sir, Nishita, what do you think is the role of HCG that is given so frequently to everybody in the first trimester, whether they are through any form of ART, if they are conceived, they take weekly HCGs till 12 weeks. Do you think that there is a role for HCG in this
currently
pregnancy?
there are mixed reviews, whatever the papers are published, but of course, whatever the studies are, there is definitely a role for HCG. You should continue it because the placenta is still forming. It is going to help in the early placental development as well till the complete placentation is done. And since she is bleeding, there's no harm in continuing it rather than stopping it. So I would probably continue that.
Amey sir, you have something else to say?
So, how are we going to know whether this pregnancy is going to survive or is it going to fail? Obviously, you can't do an ultrasound daily, okay? But you can monitor with beta HCG levels. Now, if you're giving exogenous beta HCG, then that just negates any value of doing a serial beta HCG level. So therefore, I don't know whether really giving that HCG is going to be of any help. Evidence says that it doesn't help. Practice, everybody gives that, but I think we are giving it more out of hope than anything else.
So basically it is used, as a support for the corpus luteum, which has been denuded because of pickup and other things. It replenishes what is not being supplied by the corpus luteum. So it's just to sustain the corpus luteum so that it brings about good amount of progesterone. Besides, it has some immunological effects which could be helpful from the pregnancy point of view. So there is some reason to it for as such, but I do agree with Amey that maybe directly it is not as useful.
Also, sir, if it's an FET cycle, there is no corpus luteum.
Yes.
So, giving HCG weekly is not increasing anything but her nausea.
I think it is empirical more than anything else.
Yeah, that's true.
See, earlier this was practiced, but not anymore. We have to realize that what we just heard, that there is a luteal phase defect. You can increase the progesterone support. If she is going to respond, she is going to respond. Otherwise, giving this is not going to make any difference. We used to do it earlier, but not anymore.
So here we can see from these studies that tranexamic acid does improve the dynamics of hormonal, hemostatic and ultrasound markers of abortion. As sir said, it is not embryotoxic and it doesn't have a procoagulopathic influence. It doesn't show any change in the hemostatic system. This is more significant for women who have protein C, protein S deficiency, who also have recurrent pregnancy failure, and because of which, with big bleeds, we are often scared to use tranexamic acid, wondering whether they may form a clot elsewhere, which can be, now we understand that you can freely use. Yes, sir.
Yeah, I want to just check one line on about HCG. So it was used a lot in the earlier decades, and now there were some literature which was, it was not a very big literature, but it was saying that there is a risk of teratogenicity, increased incidence, but then it was proven that evidence-based medicine does not support it. So there has been a controversy. So a lot of people, if you travel across India, if you go to the south or you go to the eastern side, they will not use HCG in the first trimester. In fact, I remember PC Mahapatra saying in a conference, do not use it in the first trimester. You know, it's very popular that it is first trimester not. So now we have dydrogesterone, which has an immunomodulator role, which was the reason why we were adding HCG to our progesterones. So that is how it gets compensated. So it may not be a necessity, and as Amey rightly said, there's no evidence base to it.
So as far as progesterone is concerned, she's already on progesterone. We decided to give her a higher dose when she has the acute bleed. There is always this question about dydrogesterone and micronized progesterone, which one should we choose and why? Sir, Kansaria sir, what's your opinion about this?
Dydrogesterone is better because, as you say, that it has got a immunological this things there. Many of these patients have an immunological factor also is there, which may be not of autoimmune but allogenic factors. So in relation to that, dydrogesterone will be much superior to micronized progesterone to be used.
And if it is long term, sir, would you prefer micronized progesterone for the rest of the duration of pregnancy, or do you want to continue dydrogesterone?
Dydrogesterone has a role only in the first trimester up till 14 weeks of pregnancy. Once the placenta is completely formed, then you may skip off it. At that time, probably maybe I personally prefer Proluen Depot at that time, after that, because it does help to quieten the pregnancy much better than maybe micronized progesterone, or though it's a little painful giving once a week or something.
It's also cost
effective.
effective.
In that case, the micronized progesterone given vaginally, HS may be on the preference.
Yes.
See, patient is bleeding also. If you give vaginal micronized progesterone, it will not serve any purpose at all because it will be washed off.
You're increasing the risk of, further disruption, infection, etc. It's proven now beyond doubt that the bolus dose that you talked about does do the trick as far as salvaging the pregnancy. The question comes, first is salvaging the pregnancy, second is supporting the pregnancy. It's a two-step thing. So for salvage, you're giving the acute bolus, and then to support, you have various options available, but I think the general consensus would be to avoid anything vaginally at the present moment, because
at least till the bleeding stops. After
so
14
sir,
weeks
I think that in the beginning slide when you showed the treatment, the prescription which was there, the dose of progesterone written was beyond evidence-based progesterone limits. So there was vaginal gel 3 times a day, and the tablet also 3 times a day. And so that was beyond the pharmacological recommendation. I'm not even talking about physiology. I'm not even talking about the lack of corpus luteum and need for it. So it is actually beyond that. And we have to be careful about what amount of it is it being given, because these are the the dosages which will continue for long, and they may lead in the, now listen to this take home message. There have been data which says there is increased incidence of cholestasis of pregnancy in the 3rd trimester with high dose of progesterone given during the pregnancy. So I have had patients where we have stopped the progesterone and we have seen reversal of the bile acids and the bile salts. So we have to be keeping that in mind, that don't overdo your progesterone, and what progesterone to use. So there is PRISM trial and PROMISE trial. The PROMISE trial for role of progesterone in recurrent pregnancy loss, and PRISM trial for the role in threatened abortion. So in one line, if I have to say, those patients with history of recurrent pregnancy loss, if they have had threatened abortion bleeding in this first trimester, there is definitely a strong role for progesterone. Rest everywhere, it's still to be found.
But this
No,
was
you're
pertaining
absolutely
to
right,
vaginal
because I have also
progesterone.
seen a patient.
This was pertaining to micronized vaginal progesterone. Now people are talking about using injectable, and we just heard about hydroxyprogesterone, Proluen Depot. What is your idea?
No, but in this case, with 2 losses, we are talking of IVF pregnancy with 2 repeated losses. Should we go by evidence-based medicine and only restrict to dydrogesterone, or should we add a subcute progesterone on the safer side?
No, in this case,
Intrahepatic cholestasis, we have lost a patient because of that.
Yeah. No.
No,
I
this
just
is
want to
for
say,
the
I
early
just want to say
trimester.
that rationally, if you think, okay, there are three things which you need to keep in mind to decide on the therapeutic strategy. Number one, that it's an IVF pregnancy. So obviously there is no natural luteal phase support. Number two is that it's a recurrent pregnancy loss. So obviously your threshold for any kind of intervention is grossly reduced. That means you want to use as much as possible. And now to complicate matters, there is frank bleeding with a subchorionic bleed. So in and she's on thinners. So keeping all this in mind, I think you need to salvage this pregnancy, and every attempt in every way should be emphasized. Obviously, you won't do things which will disrupt the pregnancy, both in the acute phase and in the long term. Long-term risk, a lot of them are there, not just intrahepatic cholestasis of pregnancy, but the sequelae of that, preeclampsia, other problems, HELLP syndrome, all they are saying that high dose progesterone, excessive load on the liver, etc., can have a role to play. So you should use judicious decision making, but at the same time, you must make every attempt to salvage the pregnancy.
Ma'am, can I ask a question?
It's not only progesterone. It's not only progesterone. We have to think beyond that. Here is an elderly patient.
Yes.
She is 41 years.
Come. No, I just wanted to ask.
Please, no problem.
And
So after you, sir, please.
And she is 41 years. She is an elderly patient. She is 41. Why are we only thinking that it is that progesterone only will salvage
That is going
this
to help.
pregnancy?
That's exactly what our next part of discussion
Because
is.
we should be very judicial, and there are side effects, complications. I would counsel this patient even before I do an ICSI, an IVF for her, that she is at risk for a loss, because when you do all this and you give her bumps on her buttocks and everywhere possible, and you drug her like that is the only savior, she should know that she has a fertility issue. There could be aneuploidy, there could be chromosomal problem, there is rejection of pregnancy. You cannot just push
it only on progesterone.
Push it that it will start.
Yeah.
No.
Beautifully pointed out that go beyond progesterone.
Yeah.
So you have to think about whether the applicator is causing a bleeding, whether there is an erosion, whether there is any polyp, whether any other
But
thing.
this is a very, very big bleed, sir. So that is why, because she's passing a lot of clots. So I think we can conclude this by finally pointing out that for the acute bleeding, we'll treat her with a high dose progestin, and then we can continue long term based on how? Progesterone of dihydrogesterone type variety, and then we put the progestins for longer time if needed.
Sorry, I just wanted to ask a quick question because we have so many experienced panelists and experts here. Now, we know that the US FDA has banned Proluton Depot, but I've been taught through my residency that it's been working wonders in threatened abortion. So I really wanted to know if you all could share some insights on how we can use it better.
2021 ACOG mentions, journal mentions very clearly that Proluton Depot has lost its recognition, which was given mainly for use as in prevention of preterm labor. But then there have been studies which have been done subsequently, they've been published. More than 10,000 cases of childhood cancers have been reported of the use of hydroxyprogesterone caproate in the first trimester, second trimester, and third trimester. Even in spite of having just one injection of hydroxyprogesterone is linked with 1.5 times raise in chances of childhood cancers. So therefore, this is something which has to be kept in mind. We have been using it as residents. We've been, giving left, right, and center as such. But today now we are seeing the consequences. Of almost 1,40,000 cases have been studied in this particular data, and has been published in the ACOG journal of November 2021.
So I think that's a brilliant take-home message that we should be very careful before using Proluton. Thank you.
So those are secondary issues. Excess of progesterone can cause hypospadias and a lot of other problems as such. It can, if you're using androgenic like medroxyprogesterone acetate, or for example, sometimes people use aquaviron, which is again a very proper the testosterone action.
Okay.
That's why progesterone, not progesterone.
Yes.
Rupa, once this case is closed, I just have one more question.
Yes, sure, ma'am. So now that we have gone beyond tranexamic acid and progesterone, what other medicines would you like to add to her so that we don't repeat what has happened to her in the past? So these.
Ashlesha, you can join us here. You are also on the panel. Dharam was also on the panel, I think.
So
That's fine.
here we can see that you can try immunoglobulins, both intramuscular and IV, intralipid, immunomodulators like hydroxychloroquine, whatever steroid she's on, like prednisolone 10 mg, you can increase the dose probably and give probiotics. So let's start with Gupta sir. What do you think? What is your take on immunoglobulins?
I would not give these drugs as an empirical. Immunoglobulin, no. Intralipid, no. Hydroxychloroquine, no. Prednisolone, specific situations, maybe, maybe not. And probiotics, yes, because of the lot of vaginal milieu being disturbed, it may be of a great value if you are using, because there's no side effect, and that's the reason. Now, all rest of the things, most of the guidelines are not in that favor, so I don't use it empirically.
Sir.
I think in the history you said that ANA was positive.
Yes.
So there is an autoimmune element to this. If you look at that, then rationally progesterone seems to be the drug that, prednisolone seems to be the drug that I would think of continuing, and I would think of escalating the dose also at the present moment. All this is to support the pregnancy. For salvage, Tranexa, stop the thinners and high dose progesterone.
Okay.
For support,
What dose would you start prednisolone on? She's already on 10 milligrams. How would you like to increase the dose?
Yeah, right now you need to double the dose.
Okay.
So
Yes,
if
Rishika.
she's already,
I
like
think,
you said,
Go ahead.
since she's already ANA positive and say she was on immunomodulators, because I've had a patient who was on everything. She was on hydrochloroquine 200 BD. She was on prednisolone even before she conceived. So she was on everything. So then, yes, then we continue all of that. And for the time being, when she has a bleed, you increase the dose. But then, like sir said, this is for making sure that the bleeding stops right now. For continuation later, for salvaging and everything, then you reconsider the previous dose.
And I think you need to look at the ANA blot.
Yes. So
You've
suppose
not-
if you have not, ANA blot has to be done.
Has to be done
So
because
it
you
is
want,
an essential
this is
rather
just
than
telling
just screening
you a
it.
quantification. You want to know a qualification, which antibody is raised, and the
And the
titers,
titers.
yeah, of each of them.
I think let me put this straight. Yeah. If we look at the evidence the way it is there today, we have a fantastic theoretical history of NK cells and TH1, TH2 ratios and cytokines and HLAs and all that kind of thing, which is very easy to convince people. But if we look at the data that is available, you look at American Society, you look at European Society, at all these places they have said that these particular use of these particular things have not been beneficial. Yeah. Of course, to add fuel to the fire in terms of confusion, you have donor cycle, you have partial immunological reaction, you have completely different kind of a immunological scenario that will happen with a donor egg. So I think, if at all, and the best part of the story is that although they are of no use, they don't have any side effects. Yeah. So I think if at all one is confused, and more so if at all one is with donor egg, or if one has got a background. Now, guidelines say that it is only the APLA and nothing else other than APLA, okay, which kind of sustains the scrutiny of science. But I think since they don't cause so much of a problem, we are under pressure. It's a precious pregnancy for a woman, for a doctor, for everybody, because there are no side effects, especially if it's a donor egg or if there is some kind of a varied immunological kind of a scenario available. Maybe you are justified in giving these kinds of things empirically, just because they don't have any side effect as such. Of them, to some extent, steroids, probably prednisolone probably will be the first one, because it has got at least some kind of evidential value. The rest of them I don't think have really any evidential value. And cost wise also, your lipids and all that is exorbitantly costly as compared to maybe a prednisolone, where you will land up, if you are giving for a long time, you will land up creating diabetes in the woman, and probably you'll have to manage her diabetes on probably insulin. But I don't think, barring that, much is going to happen with prednisolone.
What about intramuscular, this thing?
Immunoglobulin.
No, before you
No.
go to immunoglobulin, how much reliability you can give to ANA positivity?
Yeah.
Because I'll tell you two things. One, to declare it to be ANA positive, once you have diagnosed the ANA positive, you have to repeat the sample again after 3 months. And mind you, the blood has to be collected in the lab.
Correct.
Not at your place and then. And that too in a non-pregnant state preferably. So how much
basically-
reliability is there as far as the ANA positivity is concerned?
So ANA can be positive, but if it is positive in titers above 1 in 100, then it gathers significance, then it requires the ANA blood test as such. And besides that, the appearance should be speckled appearance, so it should not be something which is very just streak appearance as such. So therefore, by immunofluorescence, if you're doing, the titers should be more than 1 in 100, and if it is more than 100, then probably, an ANA blood should be done to find out what exactly is the thing which is giving rise to this ANA positive as
But
such.
now, as Datar sir said, we have this lady who is desperate and who has lost 2 pregnancies, who has bled at 6 weeks and 8 weeks and is again bleeding and coming to you. And that time you say, I will not give you any of those medicines.
See, you're saying that she's on steroids, she's on 10 milligram. So that means she has been a diagnosed case of SLE. That means she was in a remission right now when she conceived. Those are the various factors to be looked into it. Because otherwise, if the patient is just diagnosed with SLE, first of all, then in that case, she's going to be prone to so many complications in the pregnancy, especially this 42 years of age, renal complications, superimposed preeclampsia.
So, but the number of
If
women
she
who
is
are
a
just
diagnosed
ANA
case of
positive.
SLE or
No,
yeah,
she's
that
not
plus
diagnosed,
one has
she's
no
just
meaning.
ANA
Then it is
positive.
Plus one has no meaning. It's
Yeah.
going to be plus 2 or more. 1 is to 100 or more. Then only in that case it is significant.
And if she's been on steroid for such a long time, that blot is also not
So
going to give
steroid
you
is because
anything.
of what? It's because of the IVF pregnancy in that case?
So the steroid has been started because she's ANA positive and she's an IVF pregnancy.
IVF pregnancy,
Yeah.
right? Because in a SLE, the dose usually comes to 1 milligram per kg body weight.
Yeah, which is
and
very
for
low
almost
for
4 to
this.
6 weeks. And after that, it has to be tapered gradually by 5 milligram every week to a maintenance dose of 10 or 5 milligram. Right? And then to continuously judge the patient that she's developing hypertension or diabetes mellitus
Because
or
of the
renal factors,
steroid.
leukopenia is occurring.
Yeah.
What's happening? We have to judge everything.
Yeah.
That's why I said 20 milligrams 3 times a day, around 16.
Yeah.
Word abortion को miscarriage करतो.
So this is a ongoing study right now by Yang et al. What they found is women who are ANA positive, suppose they have not been structured as to whether they are mild, that is 1:100 or lower titers, or higher titers, because higher titers women get diagnosed because they have systemic complaints. Lower titers don't have systemic complaints. If they have something that is immunologically proven, if they have changes in immunological tests that they have, either you're doing an NK cell or NK cell toxicity test, to add to this ANA, then they have found that with ecosprin and lonopin, the addition of hydroxychloroquine improves the outcome for these women, because this is an ongoing trial. Right now they have proof for only if the titers are less than 1:100, there are no changes for women who have titers higher than 1:100.
Yeah, so 1:100 is a low risk. 1:300 is again into a high risk category.
Yeah, Rupa, I think amongst all the choice that you told us, I think most of us would agree on 2 of the things which seem to be practically feasible, with a benefit which is greater than the risk, and also there is some evidence, and those include steroids. And if she is ANA positive or a case of SLE, then perhaps with a rheumatologist consider starting HCQ, because the HCQ also has its own problems in pregnancy with respect to fetal cardiac issues, bradycardia, etc. So we need to be judicious when we use it, but these seem to be the 2 proven therapies which are directed when you have a positive test in the form of either a proven SLE or an ANA, where you find that on the blood there is a specific antibody which is positive.
So now this patient had been on low dose aspirin and heparin, and she had bleeding. In such circumstances, common sense tells us that these drugs should be stopped because they are blood thinners. So why were they used in the first instance? This patient had 2 miscarriages, so therefore maybe there's a logical reason for using aspirin and heparin. But this particular study, the A-Life study says that if it is used empirically, it has no benefits and should not be used. Besides
totally
that,
agree to this. If it is empirical, it has got no role. But yes, if it has got a role, then there is a lot of worry about whether to stop both or just the aspirin.
yeah. So the
And
next paper is by an Israeli paper published on RBI online, and this deals with this problem that patients who were on heparin and aspirin, those who were put empirically and those who were APLA positive. So those who were put on empirically on heparin and aspirin, it is better to stop because otherwise they would lose the pregnancy. But those who are APLA positive, it requires to be continued. The injections, the heparin and aspirin requires to be continued, otherwise they would lose the pregnancy. And this is what has been shown in a very small trial, but this is the only paper which deals with bleeding and use of ecospirin and aspirin. Ecospirin and low molecular heparin.
The number
now
of
my
APL
question to all the panelists is, suppose you have stopped aspirin and heparin, you'd like to restart it, and if you are likely to restart it, when are you likely to restart? How soon?
See, first, if it is empirical, I would not restart. If it is indicated, I would start low molecular weight heparin in such patient for a while, and I think that should suffice. That should suffice.
My question is, because there is already a blood clot inside, when will you restart?
So I think before that we need to do a PT-INR on the patient and check what is the degree of. Yeah. Then I think the moment you find that there is a resorption occurring with the subchorionic bleed and the acute bleeding is significantly reduced, I would consider restarting it if it was started not empirically but with some. Yeah.
In this case,
there are no guidelines.
That's why we have to go on to,
after the active bleeding
We
has
wait
stopped,
for the bleeding to stop.
There are no
Once-
guidelines
72
as
hours
such.
later, after the active bleeding has
But
stopped, then it's a
definitely-
proper decision. And if it by ultrasound also shows there's no further increase in the size of the blood clot, or it's showing it's on the lesser side or the same, then no fresh bleeding. Then you
One
after
more
72
point which I
hours
would
you
like
can
to
start.
highlight
Basically,
here
basically the point is that you have got APLA positive. We have somebody who is APLA positive, so aspirin and low molecular weight heparin are necessary in this particular situation. But there is a contralateral damage that she has had a subchorionic hematoma, and that's why there is a problem as to when do we start it. If you don't start it, then it's a problem. If you start it, again it's a problem. So it's a double-edged sword, basically. That's where the problem is. I don't think that we have a clarity in terms of is ecospirin better than low molecular weight heparin, or low molecular weight heparin is better than ecospirin. If both are, or each one, if one of them, then how early can we restart it? So most of the people are of the opinion that when you evidently see no active bleeding happening, you restart it. That's what is the empirical understanding. But I don't think there is any real.
So in APLA positive patients, a combination definitely works better
Always
than any one of
combination.
them individually, and therefore the reason for using a combination.
But in all the RPL investigations
now
that
my
we do,
question is, was she on 75 milligram?
She
Was
was
she on
already on
150 milligram?
Yeah.
She is
Was she
already
on
on
105
75
milligram? There is
That's a
no
great
such,
question.
no clear
There
indication
is a-
as well.
Yes. So when they talk of low dose aspirin, the dose ranges from 60 milligrams to 150 milligrams, and nobody has ever answered that question, sir. I mean, I do agree.
so when we investigate RPL women, how many do we actually get APLA positive? I mean, so many of us have been here for such a long time. How many of us actually get APLA positive? But if you start empirically low molecular weight heparin and ecospirin, how many pregnancies cross 34 weeks? So many. So this discussion, Shrutika has to say something.
When to give ecospirin 75 milligram and when to give 150 milligram, depending upon the uterine biophysical profile. So I think this year India has done this work and we should take advantage of that guideline.
Yeah, but that is for.
Can you elaborate on that?
Sir, one is when the uterine artery PI is very high, then the dose has to be ecospirin 150 milligram. And when the criteria, I don't remember the name of the criteria, the preeclampsia criteria is met, then we should do 75 milligram. I think.
I
Amaya
thought
sir-
it was based on the body weight of the patient.
No, sir, no. Amaya sir would be able to, I think.
So I think we are.
Testosterone criteria, yeah.
Yeah, I think we are moving tangentially. So this statement was for screening for preeclampsia. For screening for preeclampsia, if we do an first trimester uterine artery PI and we find that it's significantly raised, then you escalate the dose to 150. If she is on history a high risk for preeclampsia, that means there is APLA, there is some other autoimmune disease, she's a case of renal transplant, multi-system diabetic problem, etc. She's elderly, she's twin pregnancy, then you start 75 mg. But what you are saying as far as the dose which is concerned, the dose is to be doubled only if you are able to document a resistance in the uterine artery. It has nothing to do with either RPL or with the bleed.
So we'll just like to go on further. Would you like to add an antibiotic for this patient? She has such a large bleed, her WBC count is going to be likely high. Is there any role of tocolysis? Nobody wants to put her on Duadelan till the very end?
We will rely on the uterine quickening effect of the progesterone.
This will be all empirical if it is started. It will be empirical, not otherwise.
And what other investigations would you like to add in addition to a CBC because of a big bleed? Would you like to screen her for her sugars, considering she's been on a very high dose of steroid and she's had 2 previous miscarriages? So with that, we also put in a CRP because it's a very big bleed. And
instead of CRP, you should do procalcitonin, which is much more reliable rather than CRP.
Procalcitonin is going to be high only when there's severe sepsis. With such a small baby and such a small bleed, we are not going to be expecting sepsis, no, in this lady.
CRP itself is a...
Yeah, it's because of the bleed, it's going to be high. It's going to just tell us whether we keep the antibiotic on.
There is no point in starting anything.
That is to start the antibiotic.
Little infection for that little baby could be big, no?
That's the same thing with the LMWH. Such a big clot, if you stop thinner for a very long time, her placentation is going to be affected in future, and you're going to end up with a lot of IUGR if you don't keep that LMWH on. So immediately when the heavy bleed stops, you have to restart LMWH. You may restart Ecosprin a little later, but this size clot is definitely going to cause IUGR. That we are going to see in the second trimester.
Rupa, can I just summarize? So this question has been hitting around and all of us are having our own set. So let's try to objectify the whole, Dr. Saragi ne aisa chhod diya aur fir abhi apne ko food for thought diya. So we divide this patient, if it is low bleeding, moderate or heavy bleeding. If it is low bleeding, don't stop it, please continue. Usme koi side effect nahi hai. There is data which says that low molecular weight heparin is better to continue than stopping. If it is moderate bleeding and there is a subchorionic hemorrhage, what is the size of the semen? 20 to 25% अगर separation हुआ है तो कुछ नहीं होने वाला है. 50% से ज़्यादा हुआ है, then we are worried, then we have to start stopping. And actually, it is an independent risk of landing up with abortion. And if it is a heavy bleeding, it makes sense to stop it because anyway, and it's a large subchorionic clot, it's going to be a problem. What is the parameter to start? So for me, if I have to evaluate, I would say like what he said, if the bleeding stops after 48 to 72 hours, I would want to start. If there is a sonographic evidence which shows that there is a sequential reduction in the size of clot, I would want to start immediately because this is what the original reason was there for starting it. And last but not the least, if it is more than 50% separation, you better warn the patient about the poor outcome and you tell them, and at that time if you are
poor outcome.
No, you warn them of the possible poor outcome, and at that time if you are giving them this low molecular weight ecosprin, the second opinion के लिए जब वो दूसरे के पास जाएगा तो बहुत बैंड बजेगी. There is medical juicing, so you have to be taking a written consent on that. That's all.
So I think we should move to our next case.
In this case, I wanted to add one more thing. Like at 12 weeks when we are doing a scan, we should ask the sonologist to scan for any membrane, intraamniotic band, which can occur in these cases because large hematomas can lead to amniotic bands which we can miss, and then we can have amputation of hand, leg or whatever. So it's very important that NT scan inform the sonologist that she had a hematoma.
They look out for it. Most of the times they report it. So I think it's a valid point. Fine.
So this is a 38-year-old lady, married since 12 years. Again, 2 previous miscarriages, now 12 weeks, ICSI conception because of PCOD. Her first loss was a natural conception, which was a blighted ovum, DNC done 8 years back. And her second loss has been a mid-trimester loss, which was an FET conception 7 months back. She had impaired glucose tolerance, diagnosed at 14 weeks. Fasting was 100, post-glucose was 139. She was on metformin 250 BD. She had Y-shaped funneling on the anomaly scan. So She had no complaints. On a routine anomaly scan, she had Y-shaped funneling. Remaining residual cervical length was 1 centimeter. A rescue encerclage was done using McDonald's technique. The next 3 weeks later, patient had pain at home. She aborted as soon as she reached the hospital. She had adherent placenta which had to be removed piecemeal, but fortunately no blood, no PPH. So now she has undergone another embryo transfer. She is 12 weeks. We have done an NT scan for her. And because it was an FET conception, we already started her on metformin 500 prior to the cycle. She has good glycemic control. Her NT scan is normal. Her cervical length is adequate. Uterine PI is normal. Double marker shows low risk. What is our next plan? So, Kansaria sir, what do you think is the ideal screening protocol for GDM in IVF women?
14 weeks of pregnancy would be the earliest. Usually in high-risk patients, we do screening for GDM. But these patients, usually we pre-conception as she's, hello, can you hear me?
Sir, loudly.
Yeah. So anyway, she's a diabetic already. She's conceived on that. She's well controlled. So she requires continuous monitoring anyway. Means in a non-diabetic patient who has undergone pregnancy, IVF and also, she should be screened before. And at 8 weeks of pregnancy earlier also, she should be undergoing some kind of a oral glucose challenge test. And at 14 weeks also.
A dipsy in all
then
3
afterwards
trimesters.
again at 20 to 24 weeks of weeks and 32 weeks.
Correct, sir.
But Rupa, already you have started her on metformin.
Yes, that's our next question,
yeah,
sir.
so there's really no role now for screening.
Now we are
She
not
is a
screening her.
GDM.
Not in this case, but just in otherwise,
Yeah.
in an IVF conception, when is the earliest you would screen for GDM? So first trimester is better.
The new DIPSI criteria
Than
endorsed by the National Health Mission says that DIPSI should be used for all practical purposes in India. Non-fasting state should not be required, and I mean, non-fasting you could do the DIPSI test, and please do it at the first ANC visit.
That's it.
3 times during the
All three trimesters. Now,
First visit.
this
Ite
patient,
nahi rahe.
generally. So now, giving this obstetric history, we have put her already on metformin. Why or how do you think metformin is going to help her in this pregnancy to prevent abortion?
If you're talking about choice between insulin and metformin in terms of controlling the diabetes, then probably metformin is better because it gives an added advantage of the immunomodulation that metformin will give rise to. I mean, besides, of course, the sugar control. But that's not the only thing. I mean, we'll have to look at other causes of miscarriage and probably treat it. And the main discussion probably that we'll have to think of doing is why did she have this so-called early second trimester miscarriage? Is it because of some kind of incompetency of cervix? Should we be doing prophylactic tightening, or should we be waiting and do cervical length monitoring on regular basis? I think that's another thing that we'll have to look at. Infections we'll have to rule out, probably doing urine culture or doing high vaginal swab, finding out and treating. And probably in this kind of a case, probiotic will have a lot of role to play.
So, anybody else has another take on the use of insulin? Sir said clearly metformin should be the first line. Anybody else has any other idea about this?
No, as long as it's controlled, metformin works very well.
I think the role of insulin will come when you start her on SMBG, that is self-monitoring of blood glucose. If you find that with the trial of metformin, the SMBG values are still haywire, then you require to start or tailor her insulin therapy, because you have different types of insulin. You have short acting, rapid acting, intermediate acting, long acting. So depending upon the spike of the sugar, the hyperglycemia that's occurring, as well as the hypoglycemia is occurring, you will then tailor the dose. Obviously your endocrine or diabetologist friend is going to guide you. But as far as the present Foxy step care approach to GDM is concerned, the first is MNT with exercise, 2 weeks of trial with that, doesn't work out. Number 2 is metformin, doesn't work out, then consider supplementing insulin. If she has got pre-existing diabetes and is on insulin, continue the insulin. If she is pre-existing on metformin, again subject her to this, check the control of sugar, and then move on to insulin.
Would you like to add a probiotic, Gupta sir?
Yeah, I am a big fan of probiotics. So I am going to be using a lot of probiotics in my practice.
When would you like to start it?
So if it is an IVF conception, maybe even before we start the
Embryo transfer process.
And if it is a regular pregnancy with GDM, we definitely would like to give it because it has a advantage of reducing the risk of preterm labor and PPROM. And vaginal milieu is maintained, the pH is maintained better, the risk of fungal infection is lesser, the risk of, we can go on. So that's not the topic today, but that's what I would love.
What's our next step after this? Are we planning an encerclage for this lady? And at what stage?
No, I feel we should monitor her. We can get at 12 weeks the cervical length was 3.5, the os was closed. So we just monitor
Previous
her.
history.
We see
Previous
the
midtrimester.
previous history, 2 weeks before that, we should again repeat a scan. So if it was at, I think you said second trimester.
So from the time that Dr. Sarogi took our lecture on encerclage at Cooper Hospital, things have moved significantly. The present understanding of the cerclage is that cerclage is indicated for 3 reasons. Number 1, that it's a history indicated cerclage. Number 2, it's a USG directed cerclage because now we have concrete values and cutoffs. And number 3 is salvage cerclage or an emergency cerclage, which was unfortunately we required to do that. You must really not end up doing an emergency cerclage. Ideally, you should put in the stitch much before. So we definitely know that there is an element of cervical incompetence or cervical insufficiency. It's not tested as yet. Nikita, a few weeks down the line you will have to. So it is better to put the stitch when things are better, rather than when things begin to dilate.
Yes,
I totally agree with what he has said, but we should believe in that progesterone is doing the medical cerclage part. She has to be taken into confidence.
Sir,
let me complete.
ये गठबंधन का story है. We have to use cerclage with progesterone.
No. I am coming to that finally. I'm coming to that point finally. So, we have to wait till her, anti-scan and dual marker combined testing is done. Keep a watch. See that the cervix is not shortening. Then you may not even wait for that. But you have to go through all that. And then at the anti-scan, you have to re-evaluate the cervix. But yet, you have to remember the past history. She can re-perform the same thing,
Exactly,
and
sir.
cerclage has to be given. I would give it at 14 weeks soon as I have discussed with her the combined test results. I am through that. I don't want to tell her that I'll keep on watching your cervix.
So everybody agrees on doing a cerclage. Yes, Ujjwala
because
ma'am.
in this case there is a previous history of cervical dilatation, there is previous history of Y-shaped funneling. Then why should we wait for one more mishap to happen?
So
You should
what
do a
would
cervical
you like to do an
encerclage.
NIPT prior to this encerclage?
There's another angle to this because there is a previous history and short definitive proven track record the cervix that she's 38-year-old. And there is anyway an indication for finding out and donor था कि इसका इतना मेरा ध्यान में
नहीं,
नहीं
सब
गया.
self है अभी.
Self है. So definitely she is a high risk candidate. So why not do an NIPSS as early as 10 weeks?
Yes.
And don't wait till
Correct.
14 weeks.
Correct.
And so we'll be able to decide early and give a encerclage early.
Totally agree.
No, my point is, why do you want to do cerclage at 10 or 12 weeks?
नहीं NIPT
We are doing the
You
reporting
do
at 10
NIPT
weeks.
at 10 weeks.
We will send the sample at 9 in the 10th week. The report will come in 11th or 12th week, and 12 weeks पे हम लोग करेंगे sir. And we don't want to wait till 14th week. That's what I'm saying. Because यहाँ
नहीं.
decision has been taken.
No,
and
but my question is, what is the harm in doing cerclage at 14 weeks?
No,
So
sir,
we
sir.
should do at 14 weeks.
No, he's
Cerclage is
telling that
happening.
do it at 12
He is
weeks.
saying NIPT you do at 10 weeks. उसको 2 हफ्ता लगेगा ना
2
result
हफ्ते में
आने में.
रिजल्ट आ गया, 12 वीक में cerclage करो.
Okay. So there is no harm, but there is definitely no harm in doing it 12 weeks when there is a proven track record, and we know that there is a cervical incompetence which has been diagnosed, and we are aware that there is a high risk. So it is a choice of the surgeon that which is a better option.
Now the question arises, why incompetent toss occurs only in mid-trimester?
See, that early, 10 weeks thinking of it and 12 weeks finishing it off, we have to understand that what is incompetent os. What is going to matter with few grams of this embryo, and it is going to cause, pressure on the cervix and all that. Progesterone is on. You do NIPS, I totally agree, because she's a high-risk patient with previous eventful obstetrics, what she's gone through. And once you do NIPS, yet you can wait till 12 weeks. It is not a rush to rush. 12 weeks? 12 weeks.
Can I make a comment, please, here? May I? So everybody is talking about NIPS and circlage and everything, but what about your NT scan?
That's what is said. Already
that
said.
has to be.
Already said. Already said.
मैंने एक भी बार नहीं सुना.
Already said.
पहले ही बोला.
Okay, so
that is why 14
no
weeks.
stage before NIPS.
That is why
NT scan.
That is why 14
So
weeks.
अब बेला खड़ी हो ही गई है तो एक और एंगल ऐड करते हैं. There is now a role for IVF. You talked about screening for GDM. There is a screening for preeclampsia also.
Yes.
By ophthalmic artery Doppler. So now there is an amazing role. Now please remember that this is something which we all are going to be seeing very soon, because the sensitivity and the specificity is very high. Almost 100% identification of screening at 10% false positive rate for an ophthalmic artery Doppler combined with uterine artery Doppler at the NT scan time, which gives us a very good preeclampsia risk prediction at a later stage, at as early as for early preeclampsia is 34 weeks, and even at later at 37 weeks. So this is another interesting
But
takeaway.
yes, but practically we are still struggling with people doing even uterine artery Doppler. So
बाकी
I'm
वो
happy if mean uterine artery PR.
मैडम आप
Doppler.
खड़े हुए तो इसलिए बोलना तो पड़ेगा ना मैडम.
Yes, so let's just.
No, so one more interesting thing, there are only 5 cases which are needed, unlike in NT, where you have a very long learning curve. An ophthalmic artery Doppler is only 5 cases is the average time taken for an individual to learn ophthalmic artery Doppler.
Yes.
It is
So
so
I think
easy.
we can go on and on, but I think there are enough signals. We've got to proceed
We have
with the
to now come
evening as
to
such.
a close to this. So just let's quickly finish this. What type of encirclage would you prefer and why? And what material would you use? Would you repeat a McDonnell as an elective? Would you want a vaginal Shirodkar? Would you want a modified vaginal Shirodkar? Or would you want a lap encirclage?
I'll go ahead with typical Shirodkar circlage using Marcelin tape.
Is everyone on the same
That
page
has
here?
been proved and best method, let me tell you. Just because Western country people come out with their own modifications, that doesn't mean that we have to follow it.
And
Acha,
they
now-
don't want
now
to
I-
mention Shirodkar, and that is the reason why they say higher the level,
Yeah,
the better
that's
it is.
the- that's
But
the
they will not
basic
still
idea.
mention Shirodkar.
I don't think that I like to ever do McDonald's or straightening at all. I mean, now it can be a question of, it can be a discussion and debate whether this case is a incompetency proven one, whether we should do a circlage at 3.5 centimeters or no. But if I am doing a circlage, it will always be Shirodkar gel circlage.
I think,
I have
we
been
can
using
go on.
polyester tape instead of Marcelin tape, and there is data to say that it turns out to be cheaper and almost equally effective. So I have been using polyester tape for quite some time and happy with the results.
Rupa, can I make a quick point?
Yes, sure.
So 3 important principles that you must do while you are doing the circlage. Number 1, that you must use the conventional Shirodkar circlage because that's the highest circlage. Barobar na sir? Yeah. Because here the funneling is the pathology that you saw first, not the shortening. So therefore you need to go as high as possible. Number 2 is that you should use a strong enough suture material. And number 3 is that when you are tying, it should be a tie around the cervix as much as you can. And in Shirodkar's monogram, he says that the grip at the level of the internal os is what determines the success of the circlage.
So we've all...
That again brings us to the question, why mid-trimester abortion occurs only in incompetent os?
I think, sir, we can go on and on. I know this is such an interesting topic, we can still go on and on, but there are pressures from the organizers and like we should wind up, I think. Yeah.
See, basically it belongs to Reynolds phenomenon. I don't know how many of you are aware of it. It's Reynolds phenomenon. What happens if you look at the development of the baby and the growth of the uterus, it is spherical. Till 12 weeks it is spherical, and if it is spherical, what will happen? The resistance if there is no resistance at the level of internal os, the internal os will be taken over. But after 12 weeks, the uterus shape changes to pear shaped. Because of resistance occurring at the level of internal os, it becomes pear-shaped, and that is why you don't get incompetent os. If there is no resistance at the level of internal os, it will continue to remain spherical and it will result into mid-trimester abortion.
I think let's thank all the panelists for having done a wonderful job.
Thank you, everyone.
And I must admit, Rupa has done an extremely good job with
thank
the
you so
proper
much, sir.
presentation. Thank you from our side.
Thank you so much. Thank you, panelists. Thank you, expert panelists. Thank you for your wonderful contribution. I just want to ask Agarwal sir one question.
Yeah.
Will all IVF conceptions end with cesarean section? That is one question that we need. We can't close this panel without that answer. Do you think that all IVF pregnancies should deliver via C-section, or is there any scope for vaginal delivery in an IVF pregnancy?
No, in cases...
It is not a high risk, it is a challenging pregnancy. So the patients who are high risk, they come alone or with a lot of friends and big file, they are the high risk.
That's a good one.
Otherwise, no patient is high risk. The patient brings with big file, lot of collections, bag with full of medicine, they are the high risk. Because they change the doctors every day. So whether to do the cesarean or not, I ask the patient कि कैसे pregnant हुई. वो बोलेगी कि gynecology, pediatrician, neurologist, sonologist, pathologist, उनके कृपा से और सबसे बड़ी कृपा साईं बाबा की, उनकी कृपा से हुई है. तो बोला मैं उनको यही बोलता हूँ कि लोजी मतलब तो सब तो वहाँ देखे आए हो, हमारे पास में क्यों आए हो? गायनोकोलॉजी तो वहाँ देखे आए हो, पैथोलॉजी वहाँ देखे आए हो, सोनोलॉजी वहाँ देखे आए हो, तो हमारे पास में क्यों आए हो? तो हम तो सिजेरियन नहीं करेंगे, नॉर्मल डिलीवरी नहीं करेंगे.
No, so if the patient is young, if she has no high risk factors, there is single embryo transfer.
सबसे बड़ी बात है कि पेशेंट 40 वीक्स तक वेट भी नहीं करेगा. वो हमारे पास आएगा तो सीजरियन के लिए आएगा, नॉर्मल डिलीवरी के लिए नहीं आएगा. नॉर्मल डिलीवरी और सबसे बड़ी बात है, मेरे पास में पेशेंट आते हैं ना कि તમે હજુ સુધી કરો છો કે નોર્મલ ડિલિવરી કરાવવાની છે, તમે હજુ સુધી કરો છો કે what they are asking, I don't know.
So the take home message for this question would be, whatever you counsel the patient, please take all the consents if you are giving a vaginal trial, because they won't spare you if there is some mishap.
Okay. So I think... Yeah. Okay. Thank you so much, panelists. Thank you, expert panelists. Please, we welcome you on stage. Ajay.
We request the experts to please felicitate the moderators and the panelists for today. We would like the experts to please felicitate the panelists for today. Dr. Raju Sahitya sir. We'll do it in the end later on. Dr. Jignesh Kansaria sir. Dr. Nishita Parekh ma'am. Dr. Ujjwala Neta, ma'am. Mukesh Gupta, sir. Dr. Rajkumar, sir. Would request Dr. Saraugi sir and Dr. S.N. Agarwal sir to present an award to Dr. Amay Purandre sir. Dr. Nikhil Datar sir.
It gives me a sense of great privilege and honor to receive this award from my teacher, Dr. Sarogi. My first clinic in OBGYN was taken by Dr. Sarogi in Cooper Hospital. We fought against the dean to remain in Cooper Hospital. Sir knows about that. We were only 5 students. Dr. Nikhil Datar's brother was one of my batchmates, and we had 7 faculty to teach us. So it was a great learning. Also, it gives me a sense of great satisfaction that 2 of my students, Dr. Nitin Shah and Dr. Anurag Bhate, one has already become president and is ending his tenure, and one is going to take over from the other one, like how we used to take in the Wadia labor ward. So it gives me a sense of great satisfaction, and I feel extremely proud of both of you. Thank you. Last but not the least, I'd like to thank AFG for inviting me here and to give me this honor. Thank you so much.
So, it gives me great pleasure to thank all our esteemed faculties for today. The very learned faculties who made us learn about IVF and infertility right from basics to advanced, and I'm sure there is a good carry home message for each and every delegate who's attended this conference today. And this conference wouldn't have been possible without the conveners for this CME, Dr. Mohit Saraugi, thank you, and the co-conveners, Dr. Rupa, Dr. Shrutika, Dr. Sheetal, who made this wonderful, brilliant program, scientific program for this CME, and who have taken lots of pain to make it successful. So we are thankful to them, and of course all our seniors, our AFG family, and we know that no scientific program is possible without our academic partners. So I would like to take their names. Thank you for your support. Sun Pharma, Mayor Pharma, Nopex, UNS, BSV, Vivian, KK Surgical, Gufic, Mankind, JB Sharma. Hope I am not missing any of the pharma companies who have given their academic support. And of course, all the delegates, without whom no CME or no conference is over. So thank you so much each and everyone for taking active participation in this conference, and on behalf of our AFG family, I thank you from core of my heart. Thank you so much. And after these wonderful academic sessions, now we are going for the entertainment segment which I'm sure everybody is looking forward to. So, yeah. You're going to invite?